Good afternoon. The Legislative Rural Caucus is hereby represented today by Assemblymember Mariko Yamada and myself, and she's reminding me that we celebrated today honoring the Year of the Tiger, and we are Tigress ladies. So we're.
And Madam Chair, if I may say, we are Year of the Metal Tiger.
Oh.
It's even more significant.
Okay. Well,
It takes steel resolve to deal with this.
Well, thank you, and I do appreciate you being here. I'm assuming there'll be other members in and out, and I would not want to use up a lot of time from my point, but I want to welcome everybody. I really want to thank all of you, and especially some of you that have come from far to be here today with us. And it's such an impressive lineup of speakers. I'm going to try to keep us on time and on schedule. That isn't always easy because I do like free flow of information and interaction. That's what these things are supposed to be for. But at the same time, we want to be cognizant of everybody's time commitment and make sure we get everything on the record. I would just also like to say that the Rural Caucus is a bipartisan, bicameral body throughout this House here that recognizes the needs of rural areas. I will tell you that for my part, and I probably can speak for former Supervisor Yamada and myself, both former county supervisors, we have a great interest in this, but if there's anything I've learned, it's that one size does not fit all. Now, I usually joke and say, as a woman, I've purchased many articles of clothing that said one size fits all, and they did not fit my all. But the serious nature of what we're going to talk about today, one size does not fit all. And I just think it's important that we recognize that difference, and in particular when it comes to issues within the rural areas of the state of California, how they can differ. And I used to say, as president of the California State Association of Counties, hi, we're the counties, we're alike different. So the issues may be similar, but the solutions may not always be the same and may not be applicable depending on where you are. So I am hoping to listen and learn. And with that, I think we will get started. I want to welcome another former county supervisor. It's County Supervisor Days. Senator Chesborough, now Assemblymember Chesborough, joining us here. So thank you. Before I do get started, if either one of you would like to comment, now's a good time. If not, we'll proceed.
Well, Ms. Conway, thank you, and thank you all for coming. I just wanted to say that aside from being from Yolo and Solano counties, which are still remaining about 92% zone ag and rural, we have a lot of city folk in our district as well. And it's my hope that we can bring together interests and the hopes and aspirations for healthcare reform for all the people that we serve. So thank you very much for being here.
Senator?
Well, thank you very much, and I'm really thankful to the Rural Caucus for putting this together. I've been working on rural health care since I was a county supervisor. I think we all have, and during my time in the Senate, engaged in a number of efforts. And my general description of where we stand with rural health care is everything that's wrong with the healthcare system in California is worse in rural California, and you could say, well, the canary in the coal mine, because really the symptoms that are happening for the rest of the state are happening first in our communities. So fortunately, we have a number of innovators in rural communities who've done great work and have struggled in spite of all the lack of state and federal support, and I know we have a number of them on the agenda today. So hopefully we can get some good ideas about how we can join together in a bipartisan way. Because frankly, if we rural legislators don't stand together and put up whatever other differences we have aside, we have very little hope because there's so few of us out here in rural communities. So I do think it's very important that we find a way to build a team across boundaries and work together for the good of our rural constituents.
Well, thank you. Thank you both for being here.
I couldn't hear you.
Thanks. It's so great to have help, which is what we're going to talk about today, isn't it? So real quickly, a little bit of housekeeping. Today we will have 19 experts in rural health, and we're going to cover 6 critical areas during this hearing. General overview of rural California and why rural health is so important. Examples of continuum of care and access issues specific to rural health safety net and infrastructure, who delivers health care in our rural areas, how and where, health information technology, workforce issues, emerging issues, and future of rural health in California. So as we said, we have millions of people. We want to have a health care system that's sustainable. Hopefully we can find solutions to that today. So we do have just a few ground rules. We are going to invite each panel up all together at the same time. And as they're coming up, in fact, we might start with the first panel and let them start proceeding up. And all presenters will have between 5 and 7 minutes to present their material and ensure that all the information is covered today, and we're going to try and keep an eye on time. We also have public comment period at the end of the hearing today. If any of you would like to do that, we will have a sign-in sheet that will be here shortly at the end of the table. CSRHA has provided a staff person to help with slides, if any of you have those, but I think we're pretty secure and set, and you'll be running the show today, and I'm really glad, so thank you very much. All right, and we're going to start. I'd like to introduce Desiree Rose. She's Executive Director of the California State Rural Health Association, who's also sponsoring today's hearing, and along with her is Herman Speltzer, Executive Director, Open Door Community Health Centers, and I'm going to let them start. And Desiree, I'm going to start with you, okay. And I think you're fulfilling 2 roles on this panel here to start with, so thank you very much.
Okay, thank you. Well, I would like to start with my round of thank yous. Thank you, Assemblymember Conway, for working so diligently with our staff over the last few weeks to pull this agenda together. I think we have a pretty impressive panel of speakers. I'd like to thank the legislators and the legislative staff that have taken the time to come here. I think you'll find that it's time well spent, and you'll walk away gaining some new insight on some critical rural health issues that are going to need your attention over the coming year. And also, I'd like to thank our members in the audience who have come to demonstrate their support for this hearing. The purpose of this hearing is to paint a portrait of rural California and to share with you the distinct challenges and opportunities facing the state in ensuring improved health outcomes and equitable access to vital health and human services for California's 5 million rural residents. My role is to provide you with a brief overview of rural California, its health care access challenges, and the role that CSRHA plays in helping to address those issues in partnership with the California Legislative Rural Caucus and other statewide organizations and local community healthcare leaders. Next. So when most Americans and even most Californians conjure up images of our great state, they tend to think first of the movie-making industries, crowded beaches, big city life. Next, places like Los Angeles, San Francisco, and Silicon Valley. But this is more like what the real California looks like. It's the 3rd largest rural state in the U.S., next behind Alaska and Texas. As you well know, one of the biggest challenges facing policymakers is grappling with the state's vast geography. The distance from Wairika at the Oregon border to Chula Vista on the Mexico border next is the equivalent to the distance between Washington, D.C. to Montgomery, Alabama. That is more than 1/3 the length of the entire East Coast from Maine to the tip of the Florida Peninsula. Next. As I said before, California is a distinctly huge state and a distinctly rural state. 85% of the state's landmass is considered rural and is home to more than 5 million people, or 14% of the state's population. In fact, 1 out of every 60 Americans make their home in a rural California community. This map on the right demonstrates the distribution of population density throughout the state. The red areas represent the urban cores, where there's a population of more than 50,000 people per square mile. The lime green to very dark green represents California's rural and frontier areas. The population density ranges from 250 people per square mile to less than 1 person per square mile. Next. One of the biggest challenges that rural advocates have at the national level is gaining recognition for California as a rural state. There are currently more than 15 different definitions used by federal programs to allocate funding and resources to their respectively defined rural communities. And California recognizes the medical service study area definition of rural. It has been adopted by the California Rural Health Policy Council, and for short it's called MSSA, and they're defined as land that has a population density of less than 250 person per square mile and no census-defined place within the area with a population in excess of 50,000 people. The map to the left shows what California looks like. Rural California looks like according to this definition. The dark orange areas represent the urban cores, but the light orange and pale orange represent the rural and frontier communities in the state. However, the two most commonly used classification systems, those of the Census Bureau and the Office of Managed Budget, result in a very different set of places defined as rural. On the right-hand side, the only places that are defined as rural by those definitions are those that are white. So, next. Rural California is a major player in the state and national economy. For example, agricultural production. California is the nation's top agricultural producer and generates billions upon billions of dollars every year. However, it's important to note that while many people equate rural California with agriculture, only 8% of those employed in rural areas work in agriculture, compared to 10% in health and human services and 9% in education. Next. Rural California is increasingly diverse. There are 107 federally recognized Indian tribes in California, and California has the second highest population of Native Americans in the U.S. There's a huge Southeast Asian population, predominantly in the Central Valley. The largest minority group in rural California are Hispanics, who in the Central and Southern California regions represent 40% of the population. In addition to those captured by the U.S. Census, there are over 1 million migrant farm workers hailing predominantly from Mexico, many of whom are non-English or Spanish speaking. They're indigenous from the Oaxacan and Mixtec tribes in southern Mexico. Next. Where am I? My slides here. Despite their important economic and cultural contribution to the state, rural Californians are less likely are among the state's most vulnerable. They're less likely to have health insurance and more likely to depend on Medi-Cal to pay for their health care services. And here are some interesting facts. 17% of rural Californians depend on Medi-Cal versus 12% urban. Access to affordable insurance products is very hard to come by in rural communities. 37% of California's rural counties do not have an HMO that provides service on a county-wide basis. Concurrently, chronic disease management is not a funded service under Medi-Cal. And some health disparities. Rural Californians are 25% more likely than their urban counterparts to die of cancer and about 16% more likely to die of heart disease. They have twice as many heart attacks in rural areas per capita than in urban, and they are more likely to be at risk for chronic alcoholism than in urban. Rural providers, therefore, operate in a very unique and challenging healthcare arena. They have to do much more with fewer and fewer resources. Rural healthcare providers lack economies of scale, and therefore they rely very heavily on state and federally funded programs to keep their doors open to provide these vital services to rural California's working families, children, and elderly populations. Next. So in light of all the above issues, the California State Rural Health Association was established about 13 years ago to provide a unified voice on rural health issues and to be the conduit for bidirectional communication between state policymakers and rural health stakeholders. Building healthy and sustainable rural communities requires multi-sectoral partnerships to address social, political, and economic issues that are critical for preserving and enhancing health and access to healthcare services within those communities. With that said, the California State Rural Health Association is the only statewide organization that brings together all sectors of the rural healthcare safety net to advocate specifically and exclusively for health improvements in rural communities. We bring together district hospitals, critical access hospitals, community health centers, rural health clinics, county public health agencies, statewide agencies, and a number of others to facilitate the exchange of information, collaboration, and advocacy to promote healthy rural communities. We work also in close partnership with a number of statewide trade associations, including the California Primary Care Association, the California Hospital Association, the California Health Executives Association, the Regional Council of Rural Counties, Area Health Education Centers, and a number of others to elevate the voice of rural California at the state level. We are funded primarily through grants provided by the California Endowment, the California Healthcare Foundation, the California Wellness Foundation, the National Rural Health Association, as well as through membership contributions. We have members in virtually every county of the state. Next. And so, like I said, we act as a conduit for bidirectional communication among state policymakers and rural health leaders, and therefore we encourage the legislators to utilize CSRHA as a partner and resource for receiving and delivering messages, information, and rural health strategies. CSRHA can serve as the statewide stethoscope, conveying the sounds of the lungs, stomach, and heart of rural Californians. Thanks for that metaphor. Rural community leaders look to CSRHA to provide a statewide megaphone that elevates the voice, their voice at the state level. And as the bridge between policymakers and rural communities, CSRHA organizes a number of forums that educate folks on the impact of legislative and administrative policies on rural Californians, and we encourage you to partner with us in some of those forums, including we do regional rural roundtables at the local level throughout the state each year. We have our legislative town hall style forum at our annual conference in November. We do a number of webinars and other types of presentations. We have a very robust communication infrastructure, including a high-profile website and an electronic listserv that disseminates information to a listserv of over 2,000 people throughout the state on a weekly basis. So during this hearing, what you're going to learn about are the core issues that are common to all rural areas throughout the state, including the complex and dynamic infrastructure of the rural health safety net and some of their challenges and opportunities, access to healthcare issues, health information technology and e-health, workforce shortages, and concluding with the emerging issues and future health of rural California. With that, I'd like to now turn things over to my colleague Herman Spetzler, who's actually the founder of the California State Rural Health Association, but more importantly, someone who has served on the front lines of service in rural communities for the last 3 decades.
Thank you and welcome, Mr. Spetzler. I would like to notice that Assemblymember Bill Monning from the Monterey, Santa Cruz, I'm probably leaving some other part out, San Benito, Santa Clara, et al., rural area of California has joined us, and thank you for being here. Mr. Spetzler.
Thank you for inviting me, and I'll try to keep my comments short so that we can stay on time. You did a great job of all of the statistics. I want to add just a couple of more that are easy to remember. 1 out of every 8 Americans lives in our great state. 70% of the 37 million Californians live below the Tehachapi's. And most of those folks that live below the grapevine live within 100 miles of the ocean. So you have huge portions of frontier and rural in Southern California, and yet so we have this huge mass of people basically from Tijuana to Santa Barbara, and if you took the Marine base out of it, it would be even greater. Now, if you also take the Greater Bay Area with its 7.4 million and the Greater Sacramento Delta area with another 2.1 million, you have 9.5 million of the remaining 12 million that are left. So you have about 3.5 million that live in the rest of the state. Huge portions of the state of California are frontier. Frontier as being defined less than 11 people square mile. If we superimposed that definition on San Francisco, you'd have 512 people living there, just to give that kind of statistic. The other part is that while it's neat to see how far we stretch on the East Coast, if you just basically tilted California from Los Angeles, you would make it to Denver. That's a visual. It's almost a third of the way across our country. So it's a huge state. In the last 30-plus years that I've been working in rural, the things that have been the most profound to me is that much of what exists in rural today sort of happened through spontaneous combustion. If you happen to have been a community that had the right leadership, you have some kind of health care. If you were unfortunate enough that you didn't have that leadership there, you have no health care. And that hasn't gotten a whole lot better over a long period of time. The next big change that has happened is that our healthcare delivery system in rural was driven by private sector docs who wanted to go to rural areas and open a practice, hang their shingle, and be that country doc. We are not able to find that group of folks anymore. My generation of folks are not repopulating our healthcare delivery system. At this point, we're getting lots of wonderful, well-trained younger folks, but they are looking to be in the Kaiser-like model or in a community health center or in some kind of group practices with a different focus on their lifestyle than they've had. That makes it even much more competitive when you look at the nation as a whole and how much of a workforce shortage we have. We have an exacerbated situation in rural. I want to take just a moment and talk about how important rural is to the state of California and how important rural is to urban and urban is to rural, because I think we don't do enough talking about that, and I actually believe that it is your role to speak with your colleagues and make them understand how important rural really is to the quality of life that brings almost 38 million people to live in the state of California. You know, whether it's the food they eat, whether it's the water that they're drinking, whether it's the fish they like to have, whether it's the wood they're using, or whether it's the great Central Valley that provides so much food and so much export. All of it is dependent on rural. And the other part of it is that urban America recreates in rural. And it's a part that we forget all the time. But there is this kind of sense of every urban person that when they're shooting up the Owens Valley to go ahead and go skiing at Mammoth, and they get a wreck at Lone Pine, that the services are going to be available to them to take care of that automobile accident. And the health care delivery system in rural is pretty much based on a formula of the number of lives times some kind of allocation. And that doesn't work for rural if we as a state want to have at least a minimum health care infrastructure throughout the state to take care of ourselves in the future. I think that is the single most important point, I think, that has to be delivered, whether it is for keeping the people healthy who work in our rural areas to provide what it is our urban areas need to have that quality of life, or whether the rural areas are prepared for an urban out-migration, which we don't talk about very much, but that we see repeatedly, whether it was Katrina, whether it is the earthquake that just happened in Haiti. The tendency for natural disasters and man-made disasters in urban areas is to go into the rural areas, at least on a temporary basis, to find refuge. Our healthcare delivery system has to be there for that kind of a surge capacity as well. The economics of rural is relatively trivial in the size of the budget that you guys have to work with. I mean, we are the dust on the budget. The cost of keeping a minimum infrastructure in rural is not an appreciable cost in the savings we have to have. And all of us recognize that we can't spend more than we have. And I God bless you that you're willing to be legislators in this difficult time that we're going through. But please understand that if you lose what you have in rural today, it will not be easy to get it back. It is not a function of competition. It is a function of collaboration that causes any kind of healthcare infrastructure to be in rural at all. And when you lose that workforce, because for whatever reason, getting them back again will be almost impossible and extremely expensive. And I'll stop there.
Thank you so very much. You mentioned the Owens Valley, which is part of the 34th Assembly District that I represent. Did you do that on purpose?
No.
But I also learned...
Could have been all tourists, too.
I learned something about, it looks like 80% of my district would be considered the frontier, so...
Yes.
Very appreciative to hear that and understand that. We may have, I'll give you, if you have a quick burning question, we can do that. Otherwise, we'll move to our next panel. And thank you both so very much. Okay, our next panel will be examples of specific health conditions where disparities in rural areas create continuum of care and access to care challenges. Health issues such as mental health, substance abuse, obesity, aging, and asthma. And that will be Connie Stewart, Dean Kaleda. Oh, thank you for saving me. And Scott Grendel. Grendel?
Very good. Thank you.
Okay. Well, thank you all for being here. Are we going to start with you, Connie?
Yes, yes.
Okay. Connie, I started to say Constance because...
You can say Connie.
That's me, too. I don't meet Connies very often. Welcome. Thank you. Connie Stewart, Executive Director of the California Center for Rural Policy. Welcome and thank you.
Thank you. Good afternoon, members, and thank you for including me today. I'm honored to be here to speak to you about healthcare access and the continuum of care in rural California. My name is Connie Stewart. I am the Executive Director of the California Center for Rural Policy in Humboldt State University. Founded in 2005, the center primarily serves northwestern California, Humboldt, Del Norte, Trinity, and Mendocino. Next slide. Sorry. However, our work encompasses most rural areas of the state. The center aims to inform and influence policy and improve health of rural people. We not only examine medical health, but we also include the health of the community, rural poverty, food security, economic development, and access to internet and transportation, as well as access to health care is a concern to us. Next slide. Thanks to a grant from the California Endowment, the center was able to conduct the Rural Health Information Survey, which is the largest, most comprehensive survey of the general population of the Redwood Coast region. We sent out more than 23,000 surveys to residents in 43 communities in Humboldt, Del Norte, Trinity, and Mendocino. In your packet is a more detailed slideshow on our research report entitled Access to Health Care in the Redwood Region of California, which was created by Dr. Jessica Van Arsdale of the CCRP, Director of Health Research. But what I would like to do today is share with you some of our findings. Although the data collected may be different in your rural area, I think what we found in the Redwood region will be resonating with you as well. Across America, this statement is true. Living in rural areas may be hazardous to your health, and CCRP's study quantifies that point. We are concerned about poverty and place as it impacts health. So let me share with you data on the percentage of, next slide, sorry, go back. The percentage of children under 5 in poverty according to the U.S. Census. I think you have the wrong slideshow. Do you? Sorry, okay, this is, keep going. Sorry you didn't get my new updated slideshow. That's the slide, thank you. As you can see, we are high above the U.S. average. For the most part, we are trending upwards. Next slide is, here's what it looks like on the map. The dark red areas are places where child poverty is between 40 and 54%. And this map is why I would urge you to protect First 5 funding during this year's budget struggle. Next. Keep going. Sorry. Keep going. Keep going. Oops, you did not get my new slide. Sorry. Keep going. Sorry. I want you to go to the slide that says access to healthcare. That one. One of the questions we asked was, within the past 12 months, were you able to get healthcare you needed? And if no, explain why. Next slide. Here's the numbers on people that were unable to get healthcare by federal poverty level. Keep going. This is the reasons that they cited. No insurance was, of course, common among people in poverty. Next slide. Keep going, please. Here, I'm sorry, scroll about 4 more times for me. Here, thank you. Do I go forward? Here are some of the reasons that people wrote down. No doctors available to take Medi-Cal. Deductibles are too high. And the hospital no longer accepts my insurance. We're common. And here is a map of the folks without adequate health care access in our region. We also ask questions about health insurance and the use of the emergency room. This slide shows the percentage of respondents without health insurance by poverty level. Low-income respondents are most likely to be uninsured, and this is interesting because they're eligible for public insurance. It's just a speculation, but I believe many people who are eligible do not sign up in our region because so many doctors are not taking new patients because of low reimbursement rates. As you can see, close to half of the respondents said that they have visited the ER who are on Medi-Cal. So they're having difficulty finding doctors in our local area. I'm sorry, folks. I'm going to scroll to food security. This slide shows that about 30% of the people living in poverty are experiencing hunger because they cannot afford enough food. And here is a slide about food security and households with children under 18. As you can see, it's extremely high. And the national average is 4.3% for this. So in our region, you can see it's almost 3 times the national average. Here's what it looks like on the map. As you can tell, hunger is a huge problem in our region. I'm going to skip over transportation. Why don't I just go on? I'm sorry. When it comes to health care, I'm sure we can all agree on the following principles. Every person deserves quality of health care. Every person should have person-centered health care home. And we must eliminate health disparities, not only racially and ethnically, but geographical disparities as well. I know it's hard to work towards these goals during an unprecedented budget crisis, but I would ask you to keep them in mind as you go forward this year. Thank you, and thank you for all you do for rural California.
Thank you very much for your presentation. Next, I have listed Dr. Collada. You're
Yes.
ready to go second? Okay.
Yes, thank you. Again, thank you for the opportunity to speak today. These are issues that I deal with every day as a physician in a rural community. I'm Dr. Dean Collada. I'm a board-certified family practitioner. I live and work in Calaveras County, which is east of Stockton, east of the San Joaquin Valley and the foothills of the Sierra Nevadas. I'm also the local health officer in Calaveras County, and I have been since the year 2000. Calaveras County is a rural community, and our population is approximately 50,000. Our medical community is comprised of 9 family practitioners, 3 internists, 2 pediatricians. That comprises our primary care base. And we have a variety of specialties represented on our medical staff of our single acute care hospital in our county, which is Mark Twain St. Joseph's Hospital in San Andreas. Mark Twain St. Joseph's Hospital is licensed for 48 beds, but with staffing shortages, nursing difficulties, it's usually runs a census of about 20 to 25 patients at any one time. We have 5 outpatient clinics that the hospital runs, as well as 1 Native American clinic that's run by a consortium of Indian clinics, and that's based in San Andreas, and that's a federally qualified health center. And Calaveras County is defined by the state and federal governments as a health profession shortage area. And so the composition of our local medical care system creates problems with access to care, especially access to specialty care. And that's what I wanted to discuss a little bit as an example of a way to illustrate some of the gaps in our medical system and what that means to patients. Being in private practice, I received a phone call several weeks ago from a mother of a 7-year-old child who fell out of a tree, and he complained of arm pain. So the mother called the office, what to do. Said, take the child to the emergency room, they'll do an x-ray, come and see me in the afternoon with the kid, and we'll take a look at it. So she comes in the afternoon with the x-ray, and it didn't take an x-ray to tell that this child had a broken arm. There was deformity of the arm. Child was in a lot of pain. So I put a splint on the arm and undertook what turned out to be somewhat quixotic effort to find a local or to find an orthopedic surgeon for the child to see. Fractures that involve the growth plate of the arm can cause problems later on in the normal functioning of that arm. So it's an important time to make sure the child gets the right care. So we have 2 local orthopedic surgeons in our community. So I picked up the phone. One was out of town. The other actually took my call, and he refused to see the child. And the reason that he refused to see the child was because the child had Medi-Cal insurance. And so I got a dissertation from the private practice physician about the low reimbursement, the difficulties of running an office, the increasing costs of overhead, and that he wasn't going to continue to subsidize, the care of people by not getting reimbursed what it costs him to provide the service. So that was an argument which I wasn't going to be able to win. So 2 days later, a dozen phone calls later, the child got seen at San Joaquin County Hospital in Stockton, which is in a neighboring county. Hour-and-a-half car ride later, the child was seen and was treated appropriately. But to me, that this case illustrated a couple of problems in our rural healthcare system. One is that the private practice physicians, typically specialists, are becoming less and less willing to participate in the Medi-Cal and CMSP programs due to declining reimbursement. The lack of a public sector safety net system of care, public hospital, county-run medical clinics for low-income patients, puts many of our rural residents, in hardship to get the access to specialty care that they need. So as a result, what I'm seeing is that more and more low-income persons are running into these barriers to get specialty care, and it's causing hardships, long travel times to other jurisdictions, and poor outcomes for some of our most vulnerable residents. So frustrated by this, I called the hospital administrator in our county. And I said, what can we do about this? We need to get, better access to physicians in our area. We need to get more physicians recruited to our community. And the hospital administrator said that one major way that our hospital is limited in addressing physician shortages is by not being able to directly employ doctors. Specialists working directly for a small hospital would be better able to treat all patients regardless of their insurance status. So I understand legislation is being crafted to address this issue, and I would recommend support of its passage, and that's one of the ways that we can get better access to specialty care physicians in our rural communities. So in closing, practicing medicine in a rural community is very rewarding for me, but solutions need to be crafted to address some of the problems of access to care, especially specialty care in our community. So thank you for your attention.
Thank you very much. It's a very sobering presentation, but one that I think some of us are certainly aware of the facts, and I really appreciate your commentary on that. I think
Thank you.
Probably Assemblymember Chesborough, who carried some legislation dealing with some of that, was probably interested in those facts and figures too. Before we move to our next presenter, I just want to yeah, Yeah, what's the right word? We've been joined by Assemblywoman Ana Caballero from the part of Monterey County, San Benito. I'm not sure all of your counties in your area, but thank you for being here with us. Okay, and we will next move to Scott Grendel, who's the Director of Glenn County Health Services Agency. Thank you.
Good afternoon. Thank you for having me here. Today I'm here to represent a mental health and substance abuse perspective, although my elderly parents live in Calaveras County, and 2 weeks ago my mom broke her wrist and it took 5 days to get it set, so your example drives home. Just to follow up on what Chair Conway said at the opening about one size does not fit all, and I like to talk a lot about the fact that if you've seen one small county, you've only seen one small county. Because not only is there diversity amongst all of the counties, but truly when it comes to rural and small counties, that diversity is exemplified. And typically, I like to say that rural counties are structurally deficient. And what I mean by structurally deficient is that there simply are, in many rural counties, not a level of government or a level of a community-based program that could provide any level of service in a rural community. There's also, as mentioned before, a lack of transportation that compounds our ability to deliver services in rural counties. We lack community-based resources, non-governmental organizations, and in fact, in most of rural California counties are the sole providers of service. We do have a lack of professional resources, as been mentioned. Many rural counties have part-time psychiatrists, and many of us have psychiatrists that are only available by video feed. And another thing that I like to point out is that most rural county departments are one person deep. And I'll use myself as an example. I actually head up 8 departments. So I'm a mental health director, a drug and alcohol director, public health, environmental health director, a welfare director, a child welfare director, a social services director, and a community action agency director as well. And that's pretty common in rural California to see that. Obviously, you're all dealing with budget and cash flow, but clearly it's compounded in our rural communities because in most instances we were already funded at a minimal or baseline level, and when you subtract from that, there's simply not enough money to even fulfill an FTE. And so the state general fund contribution, for example, to local mental health as of today funds 1 staff member. That's 1 staff member to do crisis, hospitalizations, and in-the-field work. In fact, if it wasn't for the Mental Health Services Act, I probably would have a close sign on my door today. And there's just simply not enough funding for the crisis, the hospitalizations, and the long-term care for the chronically mentally ill. And further, cash flow is really compounded in our rural counties, and when there's a lack of cash flow, it affects everything. It affects the sheriff's office, it affects our ability to make payroll, and that type of thing. In fact, as of this month, half of the services that my department has provided since July 1st remain unreimbursed. That means I am floating 30% of my total mental health budget, which equates to about $2.7 million that I'm floating on behalf of the state of California. That's local general fund that's not available to fund sheriff's deputies, meet payroll, and other important needs for our local communities. Yet, despite all of this, and that turned out to be some pretty small print, but despite all of this, there's some really good things happening in rural California. And the first reason for that is because we're so used to collaborating and working together because that's what we've always done. And so in this day and age, we're actually even better at being able to do that. In fact, I really think that because of that, rural California is ripe for reform. And when we talk about things like the healthcare services waiver 1115, rural California is actually really poised to do some great demonstration projects on that front. And if it wasn't for the Mental Health Services Act, obviously we would be in a world of hurt. And if that was taken away or drastically reduced or redirected, there simply would be no hope for reform. Because it's not about cutting programs, it's about reforming programs to deliver them in such a way that they're meaningful and valuable to our citizens, but they meet the fact that there's limited funding and resources available. And so there's lots of examples in rural California about how MHSA is making a difference. The most common one are the drop-in centers that most counties now have for youth, adults, and for veterans. These are non-clinical, non-appointment, just drop-in types of centers. These centers are consumer managed and consumer operated. So, for example, 15 to 20% of my agency staff are actually consumers, and they're working for me in fully benefited full-time positions, part-time positions, and that doesn't even include the other 20% that make up our volunteer corps as well. And they directly advise our executive level staff. So to make up for these structural deficiencies in transportation issues, many rural counties are providing in-home or mobile services that include early intervention strategies, especially since small counties cannot afford acute psychiatric care or hospitals. And so we're using things like supportive housing to bring our chronically mentally ill home and support them in the communities in which they actually live and were raised. So as an example of why rural California is really ripe for reform, here are some of the examples of innovation that's occurring in small counties today, and these are all upstream type of strategies. The first one is Second Step, which is basically a school readiness type of program that focuses on violent and problem behaviors in youth using parent education and youth development programs. The second is a student assistance program, which is equivalent to like an EAP, an employee assistance program, except for kids. Next is Project Venture, and this is an outdoor experiential type of program, like ropes courses and that type of thing for addressing substance abuse and behavior issues in our youth. One that's not up there is one that's called Impact that Nevada County, for example, is using. This is a depression treatment program for older adults, and this is something that MHSA has really allowed us to do, is to address the needs of our geriatric population, which we've been unable to do before. And then Assertive Crisis Teams, or ACT, is actually a very old model, but it makes sense today because really what this is this is mental health first aid in the field, which is unfortunately what our services have come to today. This is about the extent of what we are able to do because funding levels pretty much dictate that we can only do first aid since major systems are simply failing, and rural California has no choice but to find a better way to do our work as evidenced by the innovative approaches that I've shared with you today.
Thank you so much. I'm feeling a little guilty about even allowing you to leave the county. I don't want to be in trouble with anybody for allowing you out. Quick question, Assembly Member?
For this panel, is
yes.
this appropriate?
Yes.
At this time? As I look at our agenda, first I want to thank you, Chairwoman Conway, for convening this and all of you for participating today, taking breaks from your busy days. This panel on specific examples of health conditions. I know we had some concentration on my colleagues' Northern California area. As you heard, both Assemblywoman Caballero and I represent parts of Monterey County, Santa Cruz County, Santa Clara County, San Benito. My wife is a primary care physician. She's worked in public service since residency in a county hospital. Natividad works in a public clinic. Her patient population is primarily immigrant workforce, and some of whom are eligible for Medi-Cal, many of whom are not. The medically indigent funds of the county usually get exhausted within the first 3 to 5 months of the fiscal year, and so that source disappears rapidly. And we see this reliance on emergency rooms that you alluded to. I had a couple questions, either for you, maybe the prior panel, and maybe not at your fingertips today, but in some of the trends of higher incidence of heart disease, alcoholism, these are trends that seem to be shared by all living in rural areas and as a condition of poverty. I'm curious whether any of you have data on health conditions unique to rural areas, such as pesticide exposure, VOC exposure, higher asthma rates among children, higher dental caries among migrant children that turn into abscesses that end up in an emergency room visit, higher lead content in the blood of immigrant children coming from Oaxaca. So in addition to health issues that affect all Californians and where poverty is an indicator, do you have data or can you point us to data that show health conditions unique to rural residents and how that impacts both the types of recruitment and retention issues of care providers and specialty needs either in clinics or emergency rooms? The reimbursement issue, it's affecting all of California. It sounds like perhaps rural California more because you have a smaller universe of doctors. And then if the majority of them won't accept Medi-Cal, you have a fractional universe that you might have in a higher populated urban area. I guess it's a multifaceted question. I'll just kind of accept free flow responses where you might direct us. But a final issue related to the uniqueness of rural areas. One of the early slides showed the diversity of immigrant communities, and language becomes an issue. Competent translation interpretation services for monolingual or even bilingual doctors. My wife is bilingual, but has immigrants who don't speak Spanish or English. And so there's a greater dependence, and it's one reason private docs won't accept Medi-Cal is the patient may present and they can't communicate. So these are some of the issues I'm aware of that confront care providers, even clinics that are established to address low-income communities. Any response to some of those concerns about specific trends or incidents of disease or illness?
I could respond to one of your questions. But each year, the California Department of Public Health publishes its health status profiles, which ranks counties by a various number of health indicators. Our county, Calaveras County, historically ranks very poorly, in fact, one of the worst counties in the state in terms of fatalities from motor vehicle accidents. And the reasons that we have for that is because we have poor road conditions, we have windy roads, we have difficulty sometimes in accessing rapid trauma services. We don't have a trauma center in our community. And so year after year, we have very poor outcomes when it comes to motor vehicle fatalities in our community. And that's part of our rural nature and difficulty in getting trauma services in our community rapidly when people are injured.
I was just going to say CCRP did get a grant to do a research study in Monterey County, in Tulare County, on pesticide use, and we mapped out pesticide data for your region, and also we did wind projections, so we could talk to farmers about when it was best to spray and when it wasn't best to spray, and I would love to share that data with you. I will get that to you. Tulare County, Tulare, I believe it's Tulare, they went ahead and did a buffer zone around the school systems. Based on our data, they figured out that it wasn't really that bad of a loss to the farmers to create buffer zones around the schools. So I'll share that with you too. But they did, it's Dr. Sheila Steinberg and Dr. Steve Steinberg at our center who worked on this. So I will be in touch.
I appreciate that. I'm sure maybe there's others that would have places that we can reference, and if you would let us know that before you leave today, that would be great. Yes, did you?
I just wanted to say that one of the major challenges that we have in the state is collecting, on a statewide basis, rural-specific data. We do have two research institutions that are focusing on regional issues, but we don't have a statewide research institution, and some of the data that's out there aggregates urban, because there's a lot of rural counties out there, but because of that urban core, those statistics are aggregated into the data. And so that's one of the things, in order to inform political or policy making, we really need to amplify the need for rural-specific research in the state. So if you have any other specific questions, we could, there's data that's out there. It's just the number crunching. There's not an institution that can do it on a statewide basis, but if you have specific questions, if you contact me, I can try to reach out to our members and try to find that for you.
Okay, and as we change panels and any of you that have statistics, I think Desiree just said we could send everything to her, and then she will.
And while we're changing,
Yes,
just a comment in passing was that in relation to the data, it's obvious that we need good statewide aggregate data about rural California, but based on I think the very correct comments about the differences, it's really important that it also be aggregated to regions and individual communities, because you can't, the rural nature of Tuolumne County and San Benito County may be completely different. So
yes. and what I've just now learned is the frontier area of my, I know, it brings to mind a different image maybe than what we're talking about. Okay, our next panel, our third panel, is going to be addressing what is the rural health safety net and infrastructure, how is health care, patient care delivered in rural California, and by whom. And so I'm just going to go in order, and you can identify yourself. And who first up, we will have Gail Nickerson, Director of Clinic Services, Adventist Health.
Thank you very much. I'm
Welcome,
glad to
Gail.
be here.
Now we know which one. That's your Gail. Thank you.
I'm Gail. Thank you very much. It's nice to be here, and I really appreciate the fact that you're taking the time this afternoon to look into something that all of us think is extremely important. That's just an overview of what I'm going to talk about. I was asked to kind of give some background about the rural safety net. Our rural safety net here in California for low-income and uninsured patients includes a lot of different types of entities, hospitals, clinics. There's several different types of clinics. Public health departments sometimes provide health services, and also obviously private providers. There's also the support services like lab and pharmacy and x-ray, home health, and medical equipment and supply providers. There are different types of hospitals in rural areas. Critical access hospitals, they typically have a low census. They provide basic services. Rural hospitals tend to be under 50 beds, and what they call the GACH, or the General Acute Care Hospitals. Different types of clinics, just to keep them all straight. There are rural health clinics, there are Indian health services, there are federally qualified health centers, there are federally qualified health center lookalikes, and there are other community clinics. Public health services typically provide immunization, women's health, HIV and tuberculosis testing, and sometimes counseling for HIV. Lots of rural private providers, I think like Herman was talking about. There are those individuals who go out to be the country doctor or nurse practitioner. There's also some smaller physician groups. And physician assistants are providers in rural areas, but according to the California law, they can't actually own the practice on their own. I'm sure you know that statistically rural areas have more Medicare patients and more patients on public insurance. And there are also fewer insurance choices. Either HMOs never arrived or they've come and gone in a lot of California counties. I wanted to talk to you a little bit about all these state agencies. I know that you're familiar with them, but I wanted to kind of talk about the different ways that they're involved with rural health. CalSOAR, which is the State Office of Rural Health, has mostly administered the state rural hospital grants, the J1 program. There's CDPH, which does licensing and certification for hospitals, clinics, and skilled nursing. There's the DHCS, which administers the Medi-Cal program and also includes the primary and rural health branch. There's Mr. MIB that oversees healthy families and some other grants to expand access. First 5, administering the Prop 10 money for children ages 0 to 5. And the Rural Health Policy Council, which has provided a unique opportunity for rural providers to hear and be heard by heads of state departments. There's also federal agencies that are involved. CMS administers Medicare and Medicaid. It's a certifying entity for rural health clinics. HRSA is the government agency that oversees the public health service programs, which include the community health centers, the National Health Service Corps, and also the federally qualified health centers and lookalikes. There's the Office of Rural Health Policy, which has grant programs and also provides technical assistance to critical access hospitals and rural health clinics, and even the Department of Agriculture, which provides distance learning and food stamps. We have the Recovery Act, which has some potential impact. I was asked to speak quickly about that. There is money in the high-tech portion of ERA for hospitals and physicians who become meaningful users. They're still hot and heavy into defining exactly what a meaningful user is going to be. And there's going to be funding through Medicare Part B and also through Medicaid, which is going to be administered by the state. And I'm sure that you'll be hearing more about that. And there is some money in the ARA legislation for funding of FQHC program expansion, infrastructure, and technology. Federal health reform, I guess the main thing is there really was a little bit in the two bills that were passed, but probably not enough for rural health care providers. I wanted to quickly just tell you a story about a patient in one of the clinics that I work with. And I'm just going to read the story here. Smiling during a job interview can usually help your chances of getting hired, but Kathy's smile just made her job search more difficult. Each potential employer, after seeing her decayed and discolored teeth, decided not to hire her. So over the years, money was tight. She couldn't find a dentist that would accept Medi-Cal, and her teeth were really showing years of neglect. She was almost depressed because she was so ashamed of going out in public. She found that our clinic did accept Medi-Cal, came into the clinic, and our staff assured her that they could give her a beautiful smile, worked on her tooth at a time until it was all done. She actually sat there and cried when it was all finished. And 3 weeks later, she came back to the clinic, but not for more dental work. She actually had gotten a job working for the county, and she was already off welfare. So her smile actually changed her life. And unfortunately, she probably couldn't get this service today because of the cuts in adult dental. I'm going to talk to you just a little bit about rural health clinics before Ray talks to you about critical access hospitals and Judy talks to you about FQHCs. Just so that you know, rural health clinic is not a generic term about a clinic out in the country. It's a Medicare certification, and any legal Medicare provider in the state who qualifies can be certified. Could be a hospital, could be a community-based organization, a county, a physician, a nurse practitioner. Some rural health clinics are licensed as departments of hospitals. Some of them are licensed as primary care clinics. Some of them operate under the license of the physician or the nurse practitioner who owns them. Clinics that are owned by counties don't have to get licensed. Regardless of licensure, every RHC has to get certified by Medicare. And there are three basic qualifications to be certified as a rural health clinic. One is a non-urbanized area according to the Census Bureau. It has to be in a HIPSA or a MUA, an underserved area, and it has to have a nurse practitioner, a physician assistant, or a certified nurse midwife available to see patients at least half the time that it's open. The purpose of this program was to expand services in underserved rural areas. So most rural health clinics in California at this point are either owned by hospitals or private providers. There are over 260 rural health clinics in California. Only Missouri and Texas have more than we do. And 40 out of 58 counties in California have at least one rural health clinic. So things I just wanted to say, and I think I'm just repeating the theme here. Lots of different providers in the safety net all want to be included in work as we move forward. Strategies that work in urban environments don't always translate for rural. And every health service in a rural area is important. Just to repeat something that Herman said, collaboration rather than competition is really what helps it work. Thank you very much. And pass the clicker to Ray.
Madam Chair?
Yes.
I just wanted to briefly say that one of the best things about community clinics is that they address the diversity of rural counties, and for that matter, urban counties. I mean, I think that it's a flexible enough model that it's adaptable to particular community needs. I did have a question, which is, I noticed one of the earlier speakers described an Indian clinic as also being an FQHC. So do the definitions overlap? Are there clinics that are more than one of the categories?
You can't be a rural health clinic and an FQHC at the same time, but you could be an Indian Health Service FQHC.
Okay. Thank you.
Good afternoon, and thank you for inviting me to be here today. Our rural hospitals, and in my portion of the panel today is to talk about the rural hospitals in our state, appreciate the great support that we've received from the Rural Caucus for many years due to very dedicated legislators such as our own Assemblyman Chesbro, who I'm very pleased see here today. My name is Raymond Hino. I have been a hospital administrator for 31 years, more than half of those years spent in rural hospitals. And I am the newly elected chair of the California Critical Access Hospital Network. I'm here today to share some concerns facing our state's rural hospitals. A few photographs of our hospital in Fort Bragg, California, Mendocino County. By the numbers, there are 352 community hospitals in the state of California. 69 of them, according to the federal government, are designated as rural hospitals. OSHPD says there are 66, so there's a little bit of discrepancy between the state definition of rural and the federal designation. In either event, 19% of all California hospitals are considered rural, and 30 of them are classified as critical access hospitals, which I plan to talk a little bit more about in the next slide. The critical access hospitals are perhaps the most fragile of hospitals within our healthcare safety net. They were created in the Balanced Budget Act of 1997 as a means, by federal legislation, as a means to save rural hospitals from extinction. They may be no more than 25 acute care beds, an average length of stay no greater than 96 hours. 24-hour emergency department is required, and they must be designated as rural and at least 35 miles away from the next closest hospital. The benefit of being a critical access hospital is 101% Medicare reimbursement. Some states allow for Medicaid or Medi-Cal cost-based reimbursement as well. California does not. It's been brought up in prior legislative sessions. Perhaps it'll be brought up again. It would be another way to help our critical access hospitals. The difference between cost-based reimbursement and prospective reimbursement is dramatic. By way of example, my 25-bed critical access hospital in Fort Bragg, in year one of becoming a critical access hospital, added $3 million in federal dollars to our bottom line. And by becoming a critical access hospital, we now have experienced 3 consecutive profitable years after 10 consecutive years of operating losses. So a dramatic improvement for our hospital and most hospitals around the country. What I hope to talk to you about in my brief time, and I promise to keep it brief, are physician recruitment and employment, seismic relief, the state budget, Medi-Cal, Medicare funding, health information technology, and national health reform. Starting with physician recruitment and employment, and I don't need to talk a lot about that. That was touched on in the last presentation. But just to give you an example from my hospital, the need for physician recruitment in small rural hospitals is acute. It's due to the fact that our rural communities are less attractive, quite honestly, for young physicians coming out of their training, and because our current dedicated rural physicians are aging. In my medical staff, we have about 50 active staff physicians at our hospital. We did a recent study. In the year 2015, 58% of them will be over age 65, and the average age of all physicians on our staff will be 65.31 years of age. Merritt Hawkins and Associates is one of the leading physician recruiters in the country, and they published a report in 2008 which states, and you can read it at your leisure, they have noticed an increasing trend in physicians seeking employment by hospitals, putting those hospitals and those states that are unable to employ physicians at a significant disadvantage. We also suffer from a problem with access to specialists, and one of the areas where we have an opportunity to do something about access to specialists is utilizing 21st century technology. By utilizing telemedicine technology, and one of my colleagues who will be on the next panel, Dr. Earl Ferguson, is a leading provider of cardiology utilizing telemedicine technology is a way by which a single specialist physician can provide support to dozens of rural hospitals, thereby alleviating the problem of lack of access to specialists. This is our robot. Our hospital and several rural hospitals in the northern part of the state are utilizing this telemedicine robot as a way to provide specialist access at the bedside. Our robot is currently allowing us to keep 6 more patients per month in our hospital without having to transfer them to larger facilities. I also wanted to touch on seismic relief. There's certainly good news and much has been done, but much more is needed to be done. As you're well aware, on January 12th, the California Building Standards Commission adopted emergency regulations that included a number of seismic relief measures, raising the HAZUS threshold, and my hospital has been a beneficiary. We were HAZUS approved last year, so our facility is now considered to be SPC2 compliant until the year 2030. My main point here is that under no circumstances should a rural hospital be forced to close for failure to meet seismic regulations. In the state budget in the current year, and we obviously need not talk a lot about that to you, you're well aware of the fact that Medi-Cal reimbursement was cut by 10% for non-contracting hospitals, including rural hospitals. Due to the efforts of the rural caucus, critical access hospitals were exempted from those cuts. So again, thank you from our hospitals in the state. That was a life-saving benefit for our hospitals, and I'm sure that you'll hear from us again as the budget crisis looms. One area that I did want to talk about in a little bit of specific detail is Medi-Cal managed care expansion into rural counties. You may be aware of the fact that the California Budget Act of 2005 authorized expansion of Medi-Cal managed care into 13 additional counties between the years 2008 and 10. 2 of those counties on the list are Mendocino and Lake counties. In our 2 counties, there's a total of 5 hospitals. Of the 5 hospitals, 4 of them are critical access hospitals. One of them is a 60-bed or 70-bed hospital, which also is classified as a rural hospital. Managed care plans are most successful with healthy populations and in populations where there's an ability to contract and save through contracting. I'm urging you to please carefully consider the implications of Medi-Cal managed care in rural communities and rural counties, and perhaps consider exempting Mendocino and Lake counties from Medi-Cal managed care expansion, as many rural counties already have. On health information technology, in the next panel we'll be speaking about this in greater detail. We are encouraged about the availability of federal dollars and through the American Reinvestment and Recovery Act. Our primary concern is the time frames, both for hospitals and for the vendors. On national health reform, Gail talked about this briefly. We are kind of in a current cooling off period for reform, with more priority being placed on the economy and jobs. Concerns for all hospitals. On the positive side, we're encouraged by the fact that national health care reform is proposing to provide coverage for 95% of all Americans. On the negative side, there are tremendous spending reductions, about $150 billion over a 10-year period, with heavy penalties for readmissions, hospital-acquired conditions, and additional taxes. Certainly, hospitals should not be rewarded for doing the wrong thing, but we urge you to consider and urge our federal legislators to consider the adverse impact and fairly administering those programs. There's a number of provisions that are beneficial to rural hospitals and critical access hospitals, and I've named several of them. In summary, our 69 rural hospitals, including 30 critical access hospitals, are among our most fragile linchpins in the healthcare system, reeling from the effects of a downturn economy of historic proportions, technology and manpower challenges, and this is a a key time in our history and our ability to continue providing services, and we thank you for giving us this opportunity to be here today.
We've passed off to Judith.
Yes.
So,
Can I ask, is that slide available? I'm looking for it in our packet. Is that included? I mean, the previous one that talks about the national health reform, what the impacts are for rural hospitals. Oh, it is.
Yeah, it's in my slides.
Wanted to make sure we got a copy of that. Thank you.
okay, welcome, Judith, and I'll let you.
Thank you. Good afternoon. My presentation part is to go as an overview for the federally qualified health centers, and to give you that overview and some of the commonalities and some of the differences with RHCs. Mountain Health was a rural health clinic for 22 years before we became an FQHC. The anomaly that I bring is that this is in San Diego County, and there is rural in San Diego County. So this is our part of it. San Diego is reflective of the state as a whole. It is about 80%, 78, 80% rural, but what you do not see is the possibility that it's rural. When you think of San Diego, you think of the zoo, Balboa Park, etc. FQHCs are not-for-profits. They're funded by the Health Services Administration, HRSA. If you hear the term 330, it is interchangeable with FQHCs. That is the section under which the authorization was done. We have to be located in a medically underserved area. We provide a broadly defined primary health services, and within primary health is prevention, dental, pharmacy, drug and alcohol, etc. And then we have to have a sliding fee scale, which means that if you qualify, and we do it based on the federal government of the 200% poverty, then your fee is adjusted based on your income to that. The governance is a little bit different from RHCs. You have to have a minimum of 9 board members. 50% have to be users of the clinic, and so it started in the 60s where where they created the health centers, and they wanted the community to define what kind of care was needed to meet the community needs. And as I said, we're a 501c3, we're a not-for-profit. Who do we serve? We serve everyone. And in San Diego, we are one of the 13 managed care counties. That is extremely difficult to do in rural. And I have to say it's been a challenge trying to, at one time we had 6 health plans. You have to be credentialed in all of them. They wanted to pay you $14 a visit if they paid you that much. When you're when you only have less than 15,000 people for 950 square miles, we do meet the frontier qualification, and financially you cannot sustain it. So we have made the decision based in 1988 because our community, there are insured people within our community. We are the only health care provider, with the exception of an Indian Health Service, which is an FQHC, but they do not do sliding fee scale, but they do private pay. But we wanted to make sure that our insured patients also had access. Our furthest most place out from San Diego is 70 miles from a hospital. The closest pharmacy is 60 miles away. So there is truly an underserved area, and if we did not provide to the insured, along with many of the uninsured or all of the uninsured, then they would not have access to care. This is what I just have said. We have 3 rural federally qualified health centers, and we also have 2 urban. And then we also serve that 11 elementary schools and junior, senior high school within that area.
You serve the schools, you mean with the on-campus?
We have 2 federally qualified. They're 330 out of the 11. So we have 2 sites within the school district, and then we are trying to set up telemedicine within that. Some of these restrictions are IT issues, and the fact that sharing IT and information exchange, and also trying to get HRSA and the primary care to understand that we do not have to set up a full clinic within a school in order to provide those services. So it's policy issues that we have to deal with on that level. And the role that we play is truly the primary provider of medical, dental, behavioral health, pharmacy, x-ray, all of those services. Not all FQHCs provide all services. It's stated within the health center world. If you've seen one health center, you've seen one health center, because they're not cookie cutters, and you cannot put their structure within your structure. It's truly based on there's larger rural health clinics, and then there's certainly much smaller ones. But we are the true safety net for the community, and we provide the access to care. Telemedicine plays a vital role, but in telemedicine, because of the policy problems with the credentialing of the health plan, it is not easy in a managed care county, because if you were a specialist and are interested in providing telemedicine, then I would have to have you credentialed with all health plans. And right now, we provide care to over 300 health plans. That means you would have to be credentialed in every single health plan instead of just doing it one time. It is truly a nightmare in trying to do the credentialing part of this process. A significant role is economic. We provide a great deal of employment opportunities with that. I'm sorry, I don't know. I'm not technical. I'm not very good with technology, so it's probably my fault. But this economic development is key. We provide jobs, we provide financial sustainability, and by keeping the money within the communities. It's our staff who buys the houses. We are just at 85 employees. Over 40 of them live in the rural area. And at this point, it's very difficult. We are outside of the school district, outside of the Border Patrol, outside of the county and state, we are the employer that has the most employees at 85. So you can see that there's not an industry. It is not a farming community. We're 60 miles of border area, and yet our demographics is 69% Caucasian. There is no industry to keep anybody there to work, and it is large ranches, but not a farming community. The disaster relief, Herman referenced that. We provided those in firestorms, San Diego 2003, 2007. But the community health centers play the pivotal role in all of the floods, earthquakes, and other disasters. These were some of the roles that we played in 2003, 2007. These were not our intentions, but when you are the rural health clinic and you are the only source of an entity there, you become it, whether you want to be or not. There isn't.
I noticed some work there with the wolf pack in addition to pets.
Well, that was the most interesting. Well, I'm not saying the most interesting part. Trying to house over 275 people, provide medical care and mental health care to them, plus the wolves, was kind of taxed our ingenuity at that point. So, but we did it, and it was successful. The challenges, the decreased and elimination of rural health programs and funding by all layers of government has truly impacted us. I have the sad news today of saying I eliminated 7 positions on Thursday and Friday of last week. That is not something that I do or we do lightly. But the decrease by the rural health program by the state budget last year, we lost just about $260,000, which was a huge part of our funding stream. This kept 2 of our most remote rural clinics open. We are struggling to know whether or not we will close one of the remotest rural clinic, and that is the most challenged population. We have an increase in uninsured population from 2008 to 2009. Our uninsured increased 82%.
That was many of the people who had private insurance is now on uninsured because of the loss of jobs, or frankly, they cannot afford the health care premiums. So we're seeing a huge influx. But what we're seeing is the community services, because there's not another organization that can deal with the community service piece of it. We're seeing a huge increase in food pantry. We've developed our own food pantry, partnered with Albertsons, which is 50 miles away. It's not down the block. And we have over 300 to 400 people accessing food on every 2-week basis. So this, which is a total of over 600, because it's not the same group of people. They can only access it once a month under the rules of this partnership that we have. They've talked about the provider shortage. It took us over 2 years to recruit into Alpine, which is only 30 miles out of San Diego. So it's even quasi-rural that has difficulty with attracting good providers. But then that doesn't mean that we don't have a problem with x-ray techs, behavioral health providers, and truly good staff all the way around. It is limited personnel. Why we're unique, we really are truly moved to serve the unique needs of the communities and the increasing needs, and we're data-driven, and we have to develop the HIT, the Health Information Technology, to do this. We work collaboratively with hospitals. Our hospital is 65 miles away, so it's not like it's a neighbor. We would like to have one, but that will never happen. And the healthcare providers. And most of all, it is patient need that drives what we do. These are some of the things how we do it, but it's trained medical interpreters and bilingual staff. The transportation is one of the biggest problems. It took me 15 years to find in our rural area, it was considered Mountain Empire, 950 square miles, to get the Metropolitan Transit bus to go from community to community, rural to rural. When they experienced budget cuts recently in San Diego, the first thing to go was the rural route. So we only had it 2.5, 3 years. It was, now we're having much greater problem, once again, getting our patients into it. Our patients in most rural reflects this. They're sicker, multiple diagnosis. It's the lack of electricity, running water. These are the things that most people take for granted, and you have to ask the question when you're providing medical care in rural. If you're asking them to soak a wound, do you have hot water? Do you have access to running water? These are key questions you have to ask. Telephones are not a norm, let alone internet or high speed. So these are some of the concerns that rural has across the board. Thank you.
Very striking statistics. Thank you very much. We've been joined by Jonah. Oh, great. Thank you.
Good afternoon. I'm actually going to talk a little bit about health IT, so I think I'm going to be a bit of a bridge between the two panels.
Great. Thank you very much. You can be that bridge man. That's good with me.
Well, thank you. I appreciate the opportunity to present testimony today. My name is Jonah Frolick. I'm the Deputy Secretary for Health IT at the California Health and Human Services Agency, and I'd like to focus my testimony primarily on 2 items today. The first is to describe the unique environment that we face today, the incredible opportunity to improve our state's e-health infrastructure, and to describe our agency's strategic planning process. And the second is to describe the challenges that we face in connecting institutions and communities with this safe and secure e-health network. So just by way of background, as you all know, after 100 years, our modern medicine is really, our healthcare economy remains a cottage industry. Primary and specialty care is delivered predominantly in independent practices, clinics, and rural health centers. Our hospitals, even those that are affiliated with chains, are largely autonomous, independent organizations. There are thousands of payers, from self-insured organizations, employers, PPO, HMO, and medical savings account plans, to government entities. And our care delivery is highly fragmented along this care continuum, with portions of our patient records scattered across it. Our communities between these institutions still relies primarily, or the communications between these rely primarily on fax and what we call the sneaker net, which is essentially hand-delivered pieces of paper. And when it comes to our healthcare economy, it represents 17% of our entire gross domestic product. It's the last major market segment to have adopted IT. It's 20 years after barcoding, 30 years after electronic banking. We still have low rates of EHR adoption, less than 30% overall, and the EHRs are electronic health records. This has contributed to our high cost and lower value than we should receive healthcare delivery system. Today, we have a unique opportunity to radically change this system. The federal stimulus program through HITECH, or the Health IT for Economic and Clinical Health Act, provides up to $45 billion nationally to support electronic health records and information exchange. It is the largest EHR program the world has ever seen. The vast majority, up to $43 billion, will be paid directly to eligible providers and hospitals, either by Medicare or by Medi-Cal, or in some cases by both, after they demonstrate what's called meaningful use of an electronic health record. An additional $2 billion will be allocated for supporting activities, and these kinds of activities include health information exchange, and $7 billion will be spent to improve the country's broadband infrastructure. So to ensure that we make the best of this opportunity, we need unprecedented levels of coordination and collaboration across these various fractured stakeholders. If we can support this, then our broadband investments in rural communities, for example, will allow us to exchange health information across our various care settings. Specialty consults will be regularly delivered over telehealth networks to patients who need them, and rural communities can be trained to effectively implement and use electronic health records. If we don't collaborate, if we aren't able to do this together and cooperate, we will build electronic silos on top of our paper system today, with minimal impact to cost, quality, and access. The e-health planning process supported by our agency was grounded on the premise that an open, inclusive, transparent, and collaborative process was absolutely necessary to fulfill the vision of HITECH. And we initiated a rapid planning and implementation process with this core principle. In April of 2009, we convened an e-health advisory board to guide the state's planning effort. The board includes members of the public and private sector, including 2 members of the state legislature. Then in May, we initiated an open strategic planning process that included public work groups, town halls, and an e-health summit with over 200 people attending. From this work, we published a strategic plan in the fall. In December, we launched an open public operational planning process to complete a detailed plan to support the safe, secure exchange of health information across our fractured delivery system. And just last week, the state received a $38.8 million grant from the Office of the National Coordinator to ensure that we can exchange information. There are a number of critical components to this plan that I just mentioned, and I want to describe 3 of them that I think are critical. The first is the Medi-Cal EHR incentive program. So the Department of Healthcare Services will be administering the payment of funds to Medi-Cal eligible hospitals and providers who demonstrate meaningful use of an EHR. Many of these providers live in rural communities. At least $1.4 billion in incentive payments are expected to be administered through this program over the next 10 years. DHCS recently completed a visioning process with the support of the California Healthcare Foundation grant, and they've since hired McKinsey & Lewin to support their incentive program planning efforts. They are one of the first state Medicaid agencies to receive a 90-10 federal administrative match to support this program, approximately $2.5 million. So that's the first, the EHR incentive program. The second is called the Regional Extension Center program. So recognizing these low rates of EHR adoption, the federal government instituted a $640 million program nationally to create 70 regional extension centers to provide technical assistance to primary care providers in clinics, practices, and public hospitals. CalREC, a collaborative supported by the California Medical Association, the California Primary Care Association, and the California Association of Public Hospitals, received grants totaling $31 million on Friday to develop extension center services across most of California, including all rural regions. CHHS, my agency, also supported a regional extension center work group as part of the planning process, and from this group emerged a Rural Health IT Consortium, a group of organizations committed to supporting critical access hospitals' high-tech needs. This organization will work closely with CHHS and intends to initiate an assessment of critical access hospitals' e-health capabilities. a first step to help them develop health information exchange capacity. And third is the broadband and telehealth program, specifically the California Telehealth Network, or the CTN. The CTN was formed about a year ago at the request of the governor to coordinate California's response to a Federal Communication Commission's grant opportunity. And it received a $22.1 million grant to establish broadband capacity, predominantly in rural communities in California. It received the grant. Once the CTN completes its contract negotiations with the vendor, it will have the capacity to connect up to 800 sites to a broadband private network. It is also seeking funding under this new federal stimulus program, and if it receives awards, could connect up to 2,000 mostly rural sites to a virtual private network. This network could conceivably deliver training, telehealth consults, web-based electronic health records, and health information exchange capacity to thousands of rural providers. So in October, Secretary Sebelius visited a rural clinic in Othello, Washington, and spoke to the power of health IT in rural communities. I visited this clinic over a year ago, and I want to show you just a couple of things that they're doing there that are really quite astonishing, that can really translate here in California, in some cases already have. So this community is called the Columbia Basin Health Association. They're in Othello, Washington. It's very rural, high desert. They have about 25,000 patients. Most of them are migrant farm workers. Most of them don't speak a language other than Spanish, or they're best served in that language. More than 3/4 of them live below 150% of federal poverty. Their payer mix is mostly uninsured and state Medicaid. 3/4 are on some form of public insurance or are uninsured. And they put an electronic health record. And when they did, they had a focus on clinical outcomes and quality. And what they wanted to do is they wanted to demonstrate how the electronic medical record can help them improve quality. And so they started measuring some clinical outcomes. And this is on diabetes mellitus, foot exams, that's what DM stands for, and microalbumin. So when they started, before they had the electronic medical record, they screened about 30% of their patients for foot exams and about 55% for microalbumin, which is a test that should be performed annually. They put an electronic medical record on in February of 2008, and within about 6 months, they were screening between 80 and 87% of their patients for these incredibly important exams. This represents about the 90th percentile of national HMO commercial plans. So this is a rural, federally qualified health center, 3/4 of which are best served in a language other or have 150% or less 150% or less of federal poverty, and most don't speak English very well. And they're still able to reach rates of screening that would put them in the 90th percentile of commercially insured patients nationally.
So can you explain how having the electronic records makes that happen?
So what it did is it
I'm not doubting you. I'm just wanting to understand the
how it happened.
causal link. You know what?
So, and I'll finish this at the end because it's pretty important. What the electronic medical record allowed them to do was it allowed them to be able to report data on their entire population of patients effectively, instead of having to go through every single paper chart and collect data and say this patient has diabetes, this patient doesn't, and put that information together in a way that allows them to say, okay, we need to bring these patients in for foot exams or for microalbumin. It was all there electronically. They could easily report it. They could easily query their database and get information about their entire population on a click of a button. Otherwise, you would have had to abstract all of their charts, 25,000 people, 25,000 charts. So it just gave them the ability, the power to do this. What's ironic about this is that EMR go live date was for their second EMR. So they actually had an EMR before that, but it was an insufficient EMR. It didn't allow them to aggregate that data together. It was like a paper record in an electronic format. So this particular EMR just supported their care processes, which were really important for them to improve diabetes mellitus. They had the same kind of outcomes for PHQ screening, which is for depression. Again, they put in an electronic medical record in February. They started at about 34% of patients with depression were screened this way. They got to 93% in about 6 months, which is almost unheard of. So, and the point is, this is what the CEO says. He says, if we can measure it, we can manage it. And they couldn't measure it with their old EMR. They couldn't measure it with paper records, but they could with their new one. It supported their philosophy and their way of doing business. So there are rural clinics and organizations in California that do this. There's places like Darren Cameron and Shasta Community Health Center. You heard, I think, from Herman Spetzler earlier, who's putting in electronic medical record. These are trailblazers who've been putting these systems in, but they don't represent the majority. You have hospitals like Ridgecrest that are leading on telehealth, and their neighboring practices that are putting electronic health records in place. But they represent the minority. They're certainly not the majority of practices. The point is that health tech really represents an unprecedented opportunity for us to modernize our health IT infrastructure and support the needed transformation of our healthcare delivery system. We strongly believe that a public-private response that is open, inclusive, fair, and transparent, that allows for the collective participants of all stakeholders, is needed to accomplish this task. Rural stakeholders have been well represented by the California State Rural Health Association, the California Hospital Association, the California Primary Care Association, and dozens of rural individuals and providers, some of whom have assumed leadership positions in our own overall e-health planning efforts. Thank you very much for the opportunity to present today.
Thank you so much. And I think it is a great bridge, if you will, to our next panel, our fourth panel.
Madam Chair, one quick question.
Oh, yes, I'm sorry.
One quick question before this panel leaves. Several of you, and obviously your whole presentation was about, the electronic medical records and all of that. But how much is the access to broadband an issue? Because that is a huge issue for connectivity and access, and the fact that, in frontier land we don't really have access. So can any of you comment on that?
I think I'll take that. San Diego Rural has had a huge issue with broadband access. It took us, we've just really had T1 lines in the rural area since 2002 when we put in teleradiography, and we had to have it. We had one line. It cost us $1,000 a month for that line. Now, because of we're able to band together, we've been approved by the federal, when the AT&T broke up. We're also part of this new CTN group that they put together. We're waiting to see who the carrier is to make sure that we've, because we have developed our own virtual private network that is as robust as we need to do it in. But the pricing certainly will allow us to put more money into healthcare access. So we're anxiously waiting for this to go forward.
It just seems to me that, the rural communities are, as Assemblymember Chesborough already said, whatever's happening or not happening in healthcare reform is 10 times worse, or, in the rural area. And access to healthcare and this whole revolution, I'm all for it. But if we can't bring the services to the people at a reasonable cost, then we're not getting anywhere.
I think that's absolutely right. Getting the kinds of resources that are needed to those rural areas, it's hard enough to get actual people there to put those electronic medical records in. Broadband is absolutely critical to help support that distance learning and training.
Okay, once again, thank you so much. And it looks like we have 4 presenters on our next panel. Thank you all so much. And we will start with Speranza Avram. Did I pronounce that correctly?
That was beautiful. Thank you very much. I've been told we're a little bit behind schedule, so I'm going to speak just very, very briefly. My name is Speranza Avram. I've lived and worked in rural communities for the past 18 years, and I'm very proud to present the State Rural Health Association's latest publication called Rural Providers in E-Health, The Future is Now. And I would encourage you all to take a look at it. It's on the web. You have copies of it. And particularly in light of some of the comments that Jonah was just making, we really deliberately used the title, The Future is Now. For those of us who have been working in rural healthcare and understanding the power of technology to really transform care delivery, we have an amazing opportunity today in front of us to really improve our communities. I think it was Charles Dickens that said it was the best of times and it was the worst of times. And I think we really are in a unique situation where on the one hand we have incredible resources that are being given to us to successfully implement e-health technology and we are in a situation where we have limited time and we have a lot of other pressures on the safety net, as you heard today, and so there will be competing priorities within some of these communities. With that, I'm actually going to turn it over to Dr. Ferguson, who is one of our role models. He is a physician in southeastern rural California and has really been one of the early adopters of e-health and telehealth, and he'll be sharing with you some of his perspectives.
You weren't kidding when you said you were going to get right in there.
Everything I have to say is in the report, so you can make it up by reading it.
Thank you very much.
I was telling Speranza earlier that I like what Pogo had to say, you know, in the cartoon. He said, we're overwhelmed with insurmountable opportunities. And that's exactly the way things are right now. I wear many hats, and that's just the two hats that are there take about 10% of my time. I also am a practicing cardiologist. I'm the only person within 90 miles that lives in the community that puts in pacemakers and defibrillators, so I get called all hours of the night and at all times. In fact, just before I left to come here this morning, I had to go to the intensive care unit, take care of some people before I could.
I think I'm going to feel guilty about having you here too. So.
So anyway, and I mention that because I'm also on the hospital board, on the California Telehealth Network board, and a bunch of other boards, because as a lot of people told you directly and indirectly in this discussion, if you're going to get things done in and for rural communities, you got to wear an awful lot of hats, and that's just the way it is. Because if you don't do multiple things, things don't get done. And what I'd like to do is give you quickly, and I'm not going to stick just with my slides because I made a lot of notes as I listened to other people. We need to think about what are the real issues that we need to solve, and then what are some of the barriers, particularly to maintaining systems after they're put into place. And I think that's going to be a big issue. Let me just see if I can make this work. You know, we talked about the rural landscape. California says we're 85% rural. The federal government Census Bureau says we're 50% rural in terms of the land area. That's an important difference. I think our California definition is correct. But because the Federal Census Bureau has a different definition of rural, it has some real implications. For example, in Ridgecrest, we're in a town of over 20,000 people. It's only about 25,000, but we're the largest community and about 10%, more than 10% of the land area of California on the eastern side of the Sierras, which includes Mono and Inyo County. Because we are considered... Rural is, yes, very relative, you know. But because Ridgecrest, the largest community in that area, has over 20,000 people, we are not eligible for telemedicine specialty consults into our intensive care unit, even though we have no pulmonologist, anesthesiologist, you kind of can go on and on, neurologist, so on and so forth, that can get reimbursement for consults into our intensive care unit from CMS, from Medicare. So therefore, most of our care is provided by general internists. And I think that's a problem. You know, the needs and the reality of rural are not matched with reimbursement. So that's one of the big issues. And Ray Hino already talked about rural hospitals, critical access hospitals. I just want to talk about clinics. Most clinics in California that are rural are single provider or small group practices. That's entirely different than the situation in urban areas, and it has some unique challenges in order to implement these technologies. And a lot of discussion about medically underserved areas. There's a big shortage of primary care services and primary care specialists, and we're having real difficulty recruiting people now. In fact, in Ridgecrest, the average age of physicians is in the upper 50s. The majority of physicians in the community are over 60. And physicians coming out of practice now want to work 8 to 5 in a clinic with no call and no hospital coverage, or they want to work in the hospital and just do that. So it takes 2 physicians to replace the dinosaurs like me that are going to retire in the not too distant future. So that's a big issue.
What happened to that work ethic that we grew up with?
There's a big difference between the work ethic now and the work ethic that we grew up with, I think.
And
we've got to deal
guilty
with
about how I raise my children.
I think it's we. And because of the lack of especially access to care, that's one reason we put in telemedicine systems, and we've been doing that since 2001. And that's why I went to the desert in '96, because just to digress, my background is I retired from the military, but I was primarily in academic medicine, and then I was in senior leadership, finally, after working for 3 years inside the Beltway in Washington and as a senior in the senior executive service, it was clear to me that people did not understand rural issues, and I wanted to go someplace to find out how we could implement these new technologies in rural areas. So that's what got me to Ridgecrest in '96.
And now stayed.
Well, actually, it's the longest I've ever lived in one place, but and it's great. And my whole concept of the problems of rural providers is entirely different than it was. And it wasn't because people in Washington that I dealt with that were on different committees trying to meet rural needs. It wasn't because they weren't trying to answer the questions. It's because they didn't understand. And that would be another whole talk. So, but the bottom line of all this is that health care in rural issues is very difficult, and it's very expensive for patients because you've got to travel a long way to get specialty care. And what happens is most people just defer the care or don't get the care because it's time off work, it's driving expenses, and so on and so forth. So it really is a big issue. Let's talk about health information technologies. Broadband, for example, in Inyo County, 95% of the county has no broadband and no cell service. And only 40% of the households in that county have access to the internet. And the distances are huge. There are only 1.8 people per square mile in that county. And so advanced health information technologies are less likely to be implemented in rural hospitals and clinics because of these issues. And also, health information technology expertise is often lacking in rural communities. For example, in Lone Pine, they did not have, they had a CEO who was also the CFO, who was also running the IT until 3 months ago, when they got a full-time IT person and a consultant. So again, many, many hats to make things happen. Jonah talked about Ridgecrest. We've been working with EHRs. We implemented a paperless practice in 2002. We actually had electronic prescribing in 2003 from our end. We could do things electronically, but it actually got to it when it went to the pharmacy. It went in there by fax, so it really doesn't mean meaningful use. But from our point of view, it was all electronic, and we actually had a health information exchange of laboratory data that came from the hospital into our electronic records automatically in 2004. So we've been pushing the envelope, and that's one reason I went to Ridgecrest. It's a very interesting community that allows us to do some things that we couldn't do elsewhere. We established the SSTN in 2001, and I've been doing cardiology consults to Inyo County, to the Southern Inyo County Hospital, which is a critical access hospital 90 miles to the north, since that time. And we're starting to extend that service to almost 200, well, actually more than 200 miles north and 200 miles to the northeast to serve even more rural areas than those. And the big problem has been broadband, but now we think that's going to be solved with the California Telehealth Network. We've been able to get telemedicine and telehealth equipment with grants, so we're ready as soon as we get the broadband, and we're going to start implementing some of those services. And that's a way to reach a lot of these communities. Death Valley is a great example. They have absolutely no access to health care in Death Valley. They have 400 permanent residents, of which 50 are American Indians with a TLB Indian Health group. But they get 1.5 million visitors every year. And any urgent or emergent care has to be air evac'd by helicopter or 2 hours of ground transportation to the nearest hospital. And what was interesting in talking to the EMS director, most people refuse to be transported when they find out what it's going to cost and how difficult it is, and so they just defer care. And that's a big problem. Major issues then are broadband connectivity. We think that's getting better. It's certainly much different than it was a decade ago, and I think we've got the funds to make that happen. Purchasing advanced HIT and telemedicine hardware, software, and services. I think the cost of that equipment has come down and the capabilities has gone up so that we are going to be able to do some things very quickly. One big problem is staffing and workforce issues, people to help us with the IT and so on and so forth. I want to talk about reimbursement because that's what you have to have in line to make things sustainable after you put all this equipment in place. Medi-Cal, after fighting with them for over a decade, now they have the most enlightened reimbursement policies about telemedicine in the country. And all you have to do is document a barrier to service, and they will. It can be somebody that's right across. It can be a clinic right across the street from a major medical center. If somebody can't get an appointment for 3 weeks, you can justify doing a telemedicine visit to get them access to care. CMS, Medicare, is an entirely different situation. We already talked about problems with not being able to get specialty care into and there are many other issues as well, and I don't have time to go into the issues with CMS, but they're not in line with really what I think things should be. In addition, all of these insurance, CMS, and all the federal regulations and insurance company reporting requirements. In the decade that I practiced in our clinic, I saw my overhead expenses go from 30% to 60% because of requirements, the administrative requirements. And then when they say, well, we're going to cut the physician's reimbursement by 20%, it doesn't come out of the fixed overhead that's required from the federal government and the other and the insurance companies. So now we've got to think about integrating these systems into telehealth systems, and it's possible to do those. We've got they're cost-effective solutions, and I'm not going to go into all the details, but the big issue is reimbursement for services, and we've got to be able to reimburse, particularly in rural and remote areas, enough to sustain these healthcare systems. And we should be focusing on what the community needs are and how we're going to overcome the barriers to access in those rural communities. So the biggest issues now are no longer the technology and no longer the effectiveness of the solutions. We can build cost-effective solutions, but we've got to have regulatory policies and funding that's in line with keeping us sustainable. So the reason we're having this hearing is to make sure that you understand the issues, and this is this is a slide of Gene Fuller, Assembly Member Gene Fuller, who came to Ridgecrest. We were showing we have one of the things that somebody mentioned was interpretive services. In the bottom left of that screen is a group of interpreters at Loma Linda. We can do real-time interactive video interpretive services. We can stabilize infants. Right now, if a neonate is born and has a significant problem and has to be cared for in Loma Linda, they have to put a team on a helicopter, fly 120 miles to Ridgecrest, stabilize the infant, put them in the helicopter, and take them back. These systems allow them to help us stabilize the infant and may also decrease the need for transport. Thank you very much.
Thank you so much. David, we're going to move next to David Ford.
Thank you, Assemblywoman. I'm David Ford with the California Medical Association. I'm wearing the hat today of CalRec, which Jonah touched on earlier. And to explain CalRec, it is a new entity and what it is, I have to talk a little bit first about what is a REC, a Regional Extension Center. It is a federal grant program funded as part of the Stimulus Act, or ARA. And the feds put some rules on.
You sure it doesn't mean what you don't want to have on a rural highway?
I thought maybe it was describing the health policy of the California State Legislature.
Okay, we've got SB 810 coming.
The sure, we're done. Okay. The feds put some rules on who could be a regional extension center or a REC. It must be a U.S.-based nonprofit organization, must be a multi-stakeholder collaborative, must be able to serve at least 1,000 providers, and could not overlap geographically with another regional extension center. And generally, the function of the RECs was to provide technical assistance to physicians and other eligible healthcare providers to achieve meaningful use of electronic health record systems. So we're trying to fill in the gaps, or the feds were trying to fill in the gaps to help solo and small group practice physicians and others to implement and demonstrate meaningful use. The funding for the RECs is available for service to what are called PPCPs, Priority Primary Care Providers. And the PPCPs were defined as physicians and other providers with prescribing privileges focused on primary care, either in small groups, individual or small group practices, public and critical access hospitals, community and rural health clinics, and other settings that predominantly serve the uninsured. So very safety net focused, and obviously all of the above speak to rural California. And the slide didn't come out very well, but CalREC is a new entity, as I mentioned earlier, because the federal rules said that the RECs must be multi-stakeholder collaboratives. The medical association or the primary care association by itself wouldn't have qualified. So CMA, CPCA, and CAPH have formed an independent entity called CalREC. It's independent of any of the three organizations, so it's not a subsidiary of any one of them. And because of the way the feds funded the REC program, CalREC actually has submitted 2 applications to the federal government, one that we call Northern California, which includes the Upper Central Valley, the Central Coast, the Bay Area, Sacramento, and the far north from here to Oregon. And then one we call Southern California, which is the lower part of the Central Valley, the Inland Empire, and San Diego. There were 2 other REC applications were submitted from California. LA Care submitted one solely for Los Angeles County, and CalOptima submitted one solely for Orange County. And with all due respect to some maybe small parts of Orange County, I think all of the area you would consider rural in California will be served by CalREC.
Can I ask you just real quickly, Upper Central Valley and Lower Central Valley, is there a line?
Yeah, and I anticipated that question. The line goes right about through Fresno.
Okay. Yeah, we seem to have that.
North or south? And through the whole public rec process that Jonah described earlier, there were about 100 different maps of California that carved up the state various different ways. The Central Valley got cut in half. Almost no one knew what to do with the Central Coast area. So that was our best guess, and part of it, as you'll see on the next slide, was trying to make the provider numbers roughly equal. So total, CalREC expects to serve, you'll see there are about 7,500 priority primary care providers. And that is about 3/4 of a statewide total that'll be about 10,000, including Los Angeles and Orange County. But obviously they have the biggest chunks in those 2 counties. And our total REC participation we expect to be about 13,000 providers. And Jonah a little bit stole my thunder from this slide, but the important piece at the moment is that as of last Friday, CalREC has received an official notice of grant award from the federal government for both Northern and Southern California. Our initial funding, which covers the first 2 years of operations at a 90-10 federal match, is roughly $31 million. And as I say, it covers the entire state at the moment except for Los Angeles and Orange counties. LA Care and CalOptimal were not funded in the first round of federal funding, but they are in a second round that is going on now. So that's all of that is just sort of the overview of CalRec, and I wanted to talk a little bit specifically for the purposes of this hearing about the challenges of serving rural California in this type of program. First and foremost, the providers in rural California start with a lower overall provider adoption rate of EHR technology, and that probably comes as a surprise to no one. But statewide, I think the number we all use is about 30% adoption, and that number is, of course, tilted very heavily by very high adoption rates in our urban centers, particularly because of the presence of large medical groups and large integrated systems and large hospitals in those areas. Second is geographic dispersion. The way that the RECs are funded is that we receive $5,000 per provider that we help. And so obviously if you're in, say, downtown San Francisco and you have a large number of providers in a very small area, it's very not easy, but easier, I guess I would say, to get large numbers of providers very quickly rather than going into, say, into Ridgecrest and those areas where the providers are very dispersed. But unfortunately, the funding works out that we get the same amount of funding no matter where those providers are. And finally, of course, the lack of infrastructure, and I mean that term infrastructure in many, many ways. There is just a general lack of broadband connectivity and what we generally think of as infrastructure, but also in those areas there aren't armies of IT consultants ready to go out and help physicians. There aren't a lot of helplines for when the system crashes at 2 o'clock in the morning. There aren't just, in a lot of ways, the infrastructure just doesn't exist in rural California in the way that it does in urban areas. And to give you kind of the top level of CalRec's approach to addressing those issues, the strength of CalRec, we believe, is our statewide approach and infrastructure with a connection to local resources. And really what California is hoping, or the CalRec is hoping to do, is to bring statewide resources to bear on the local level, and we think that will be particularly important in rural areas. And also CalRec, through our founding organizations, have local affiliates, county medical societies, local clinic consortia, just to name two key ones, that touch every part of the state, including the very rural areas. And with that, I'll pass it on to Pam Lane.
Thank you. Hi, Pam.
Good afternoon. Thanks for having the topic of health information technology on your agenda this afternoon. I'm going to shift just a little bit away from telemedicine and the Regional Extension Center subjects and tell you a little bit about hospitals. I am fortunate enough to be employed by the California Hospital Association. This is my first job outside of hospitals. I've been at CHA for about 2 years, and my life has been rural America. I am not originally from California like Dr. Ferguson. This is the longest I've ever lived anywhere. But my home of record on my military record is a place called Turtletown, which is 15 miles from Ducktown and over the ridge from Hanging Dog. Now, that's rural America. And both of my parents are retired healthcare providers.
That's great.
Isn't it? And it's all true.
Those could be in my district, though. Are you sure?
Well, and so the family business is healthcare, and so rural healthcare is near and dear to my heart, and I'm delighted to tell you a little bit about your hospitals in rural California. You've heard the numbers, that there are 69 rural hospitals and 30 of those are critical access hospitals. I think that phrase is really important. It's critical access for the people who live in those areas to have those hospitals there. Those hospitals, those rural hospitals, have provided 987,126 inpatient days of care in the last year, almost 1 million. Provided 4,186,000 outpatient visits in the last year, and 1 million of those were to Medi-Cal beneficiaries. The average operating margin for rural hospitals is 2.1%. That's a really important number to remember, because when we talk about the cost of HIT systems for hospitals, it's a little bit different than it is for clinics and physician practices. Actually, in the report that was issued in December of 2008 by the Health Information Technology Financing Advisory Commission to the governor, it was stated that the cost of HIT systems for the average rural hospital would result in a 2 to 3% reduction in operating margin per year over a 5-year period of time. So we're already at a negative operating margin to install electronic health records in our hospitals, and that's not the biggest cost. I'll get to that in a minute. And for uncompensated care costs, your rural hospitals are providing $120 million a year just in bad debt and charity care for Californians. So let me paint you a picture about your hospital. In most communities, the hospital is the largest employer in town. But it's very hard to recruit, as you've heard, both hospital staff as well as physicians into rural communities. The hospital is open, the emergency room is open 24/7. And when patients cannot get primary care anywhere else in the healthcare system, they come to the emergency room, and they know they cannot be turned away. As you saw in one of your first slides, 50% of the individuals in California living below the poverty level have made an ER visit in the past year. This is the place where in the middle of the night or at any time, when law enforcement doesn't know what to do with a hungry, intoxicated, or depressed and suicidal person, they bring them to the emergency room, and we care for them. Our issues in HIT are not just the cost, although I shared with you those numbers. Those are the what I call hard costs. That's the cost of the actual software and the system. The soft costs are actually where the rubber meets the road. You have to have all of your staff trained in a 24/7 operation, which means you're going to pull them away from patient care to put them through computer training. It's necessary, it's important, and it has to happen. Workflow redesign is huge. Also in Speranza's report, she stated that that is the biggest obstacle, the biggest barrier to implementation at this point in time. We don't want to automate the chaos. We don't want to take the paper records and turn them into electronic records. We have to redesign the workflow to get the efficiencies. It's estimated that generally there's a loss of productivity of 30%. So if you think of that not in terms of productivity, but of pulling people away from patient care to support the implementation of the systems, that would be 30% patient care that wouldn't be provided. That's huge. Workforce issues are also a tremendous barrier. One of my CIOs at one of the rural hospitals had a conversation with one of my CEOs had a conversation with me not very long ago, and he said to me, you know, Pam, I don't know what to do about this. I'm going to have a CIO. With salary and benefits, it's going to cost me $120,000 a year if I could recruit somebody here, because these people don't come cheap. There aren't a lot of them, and most of them don't want to live in rural America, or they're already there. And then I'm going to have to finance an IT department, because as another CEO said to me, I don't have an IT department. I have a high school kid who comes and keeps the computers working. That's a far cry from what's going to be needed to support electronic health records. And of course, one of the problems that we're having with physician recruitment into rural areas is physicians coming out of medical schools right now have not been trained to chart on paper. So when they come to visit the community and they say, what do you mean you don't have an electronic health record? I'm not going to write on paper. They'll go someplace else. So we all know the benefits of this, but we also know that there are huge barriers. I came to California because I was working for a vendor, and I was working with hospitals, rural hospitals only, some of whom are represented in this room, helping them install electronic health records. And by and large, the ones that I saw be successful were the ones who did their workflow redesign before they implemented. One of them didn't, and so they recruited me to California, and I was delighted to come and work at a district hospital. When you are from someplace else in the country, you don't know what a district hospital is, so I had to figure that out first. But once we got that computer system humming, things were great. This is important for California. This is important for your districts. This is really healthcare reform we're talking about. It's at a different level, but it will reform the healthcare environment. The hospitals always thank you for your support. I wanted to share with you the issues quickly, but I want to end on a high note and tell you that I truly believe rural America and rural California is where the most cooperative, collaborative, problem-solving occurs. The communities in California who are ahead of the game on this just looked around and said, there's nobody else going to do this for us. We're going to have to do this for ourselves. And the barriers between clinics, providers, physicians, and hospitals don't exist anymore. We all sit around the table now and say, how can we figure this out and how can we make this work? Not, well, gosh, I don't look the same way that you do. My facility doesn't look the same way, so we can't possibly work together. This is forcing us into a new day. And with that, I'll take any questions that you have.
Thank you very much.
You're very welcome.
That is a high note. One of the supervisors I used to work with told me that, well, you know, we're counties. We keep everything together with baling wire and bubble gum.
And duct tape.
I'm starting to appreciate that statement more and more. And I was looking for a high note because this is overwhelming statistics. And
it's overwhelming to the providers that are going to try to do it too. And CalREC's going to provide a lot of help, and Dr. Ferguson's expertise is going to be golden.
Good. I just heard you say Dr. Ferguson is not retiring ever.
Ever.
And he's going to stay awake 24/7 so he can take those helpline calls from about 11 p.m. till 5 a.m. Is that correct, Doctor? Well, thank you all very much. And this is a good segue, I think, and ending it on that note as we go to our fifth panel, which is workforce issues, because you kind of touched on that, workflow and workforce issues. So our next panel is coming forward. I appreciate all of you, and we've really been doing good on timekeeping. I'm usually chronologically challenged, so I appreciate all of you getting us the information and quickly, and then we have our backup info to go with it. So with that, we'll start our fifth panel, and you must be Angela. You have the clicker. You're listed first. Angela Minifield, Deputy Director, Office of Statewide Health Planning and Development. Thank you so much.
Thank you. Greetings, Conway Chair and other members of the Rural Caucus. It is my pleasure to provide an overview of various health workforce challenges that are facing rural California. Specifically, I will be providing you with the context for the other panelists who will provide some local and regional examples of issues that are impacting workforce in their rural areas. I'm going to start by providing a definition of healthcare workforce, and specifically the healthcare workforce is the labor pool that is needed to facilitate the delivery of healthcare to the population. It does include a range of health professionals, including physicians, nurses, therapists, technicians, technologists, aides, public, mental, and behavioral health workers. I'm also going to provide you with the definition that we use to identify a rural area, and this has been alluded to by some of the other speakers, but again, just to provide you with a context, a medical service study area, a rural area is actually a medical service study area with a population density of less than 250 persons per square mile and contains no census-defined place with a population exceeding 50,000. There are 541 medical service study areas in California. Approximately 242 of those are either rural or frontier, and the other 299 are actually urban. The number of Californians currently living in medical service study areas are a little bit over 5.4 million. This slide is meant to really depict the number of rural Californians that are living in health profession shortage areas, specifically primary care health profession shortage area. Those are areas that have 3,500 persons per one primary care physician. There are nearly 2.3 million Californians living in those areas. In mental HIPSAs, there are over 2.3 million. And in dental health profession shortage area, there are over 940,000 Californians that are living in these areas. You should keep in mind that these are areas in which communities have applied for such a designation, and there may be additional Californians living in these areas who actually have not submitted an application for health profession shortage area designation. I'm going to describe a few of the issues with regard to workforce recruitment in rural areas. Someone has spoken to the number of hospitals that have been decreasing. Specifically, I'm aware that at least 3 hospitals closed between 2001 and 2005. That is rural hospitals. These areas also have, let me catch up with the slides here. The areas also have low provider to population ratios. There are limited education and training opportunities, although there have been some efforts by Governor Schwarzenegger to increase education capacity, specifically with his investment of the $90 million over a 5-year period for his nursing workforce initiative, as well as the recent Allied Health Initiative that was launched last spring, which provides over $32 million over a 3-year period to expand education and capacity, again, for allied health. There are several rural counties with aging primary care physician workforce, and it makes it difficult to recruit younger physicians. As has been referenced earlier, there are some technology challenges. There are significant numbers of rural residents without health insurance. Transportation continues to be a barrier to health care access, and also there is limited professional and social peer group interactions for health care providers. Despite some of the challenges, there are several programs that are really aimed and designed to address rural health access issues, either sponsored through our office or other entities within state government, including the Department of Health Care Services, as well as the Labor and Workforce Agency. I'll touch upon a few just because I know that we are very limited in terms of time. The Song Brown Healthcare Workforce Training Program, for example, provides over $7.1 million in funding to family medicine residency programs, physician assistant, nurse practitioner, and registered nurse programs, specifically assisting educational institutions to provide clinical training opportunities in medically underserved areas, including rural areas. And this is important because compared to about 12.5% of primary care physicians who would typically elect to practice in an area of underservice, about 54% of Song Brown trainees actually end up practicing in an underserved area, whether it be urban or rural. The California Search Program is actually a new program that is sparked by stimulus funding and is a partnership between our office, the California Primary Care Association, and the California Area Health Education Centers. This provides clinical training opportunities to students who would want to practice 4 to 6 week rotations in a community clinic or a health center throughout California. I will touch on, because this was mentioned by Desiree earlier, the Healthcare Workforce Clearinghouse Program and the specific need for data to really illustrate where providers are practicing in California. The Healthcare Workforce Clearinghouse Program is a new program to the Office of Statewide Health Planning that allows our office to be a central repository for both healthcare workforce and education data in the state. And specifically, we will be working with the health licensing authorities, also with EDD's Labor Market Information Division and the public university systems to really assess the current supply of healthcare providers practicing in California, as well as identify what some of the demands for future healthcare providers are, and what does the population, the population of providers look like in terms of geographic distribution, race, ethnicity, language proficiency, et cetera. I want to mention the Health Professions Education Foundation, which is a nonprofit 501c3 within OSHPD. and also provide scholarship and loan repayment grants to individuals from an array of health professions, nurses, physicians, allied health providers, etc. You should also be aware that at the federal level, there was over $200 million that has been provided through American Recovery and Reinvestment Act funds, and the applications for loan repayment specifically are being accepted through July 29, 2010. This provides opportunities for various healthcare providers to receive up to $120,000 of their debt repaid in exchange for them working in a health profession shortage area. There are some other resources that are provided by our office in terms of news alerts. We do post calendars of events identifying various health workforce briefings, conferences, etc. We have a Healthcare Pathways newsletter that is circulated electronically to increase awareness of various healthcare careers. And we also have scholarship and pipeline program listings for students who may be interested in pursuing the healthcare profession. And for more information, you can visit our website, join our mailing list to receive the e-news briefs that I mentioned, and or request information from me directly.
Thank you so much. Okay. I'm going to have to ask you if you are Linda or Kathy.
I'm Linda.
Okay. And I apologize for not knowing that.
So that's okay. Why would you know that, of course?
Welcome, Linda.
Thank you. I'm Linda Zorn, the director of the Regional Health Occupations Resource Center. I'm located at Butte College. I serve the Far North regions. And Rourke is a part of the California Community College Economic and Workforce Development Program. The purpose of my presentation is to highlight the workforce needs and then look at the opportunities to respond to those needs. My office did an environmental scan called Careers in Allied Health, Northern California region in 2009. I'll just highlight a couple of the details of this scan. We found that by 2017, the healthcare industry is projected to grow by 23% in Northern California. The last point is, I think, astounding. 5.1% of their current workforce, 6,400 employees, will retire in the next 3 years in Northern California. These two slides, and I'm going to go a little bit quickly to make up some time. If we look at both our 5-year and our 10-year projections, we see that the largest growth is going to be still in the nursing area. We come up with medical assistants, home health aides, and we look at a lot of job growth, over 1.1 to about 1.26 million jobs. So we know that there's a shortage of allied health workers. There's a lot of data to demonstrate that. What are we going to do? We have a proven delivery system in California, that's our community colleges. Statewide, we offer 6,300 certificates and degrees in over 72 districts. And because I work with the rural Northern California, I know that these rural communities rely on the community colleges for their workforce development needs. So I think it's going to be an important part of our strategy to look at what we can do to make sure that we continue to fund the community college system and the CSU and the UC to provide the workforce that we really are going to need. In addition, people have talked about distance education, and we have had a good history of doing RN training, radiology technology training, and many other forms via distance education to reach our most frontier areas of the state. Just want you to look at that purple graph here, which shows, this whole slide shows the numbers of graduates we have had in our program. That purple is nursing. Just look at how large that is. And on this slide, I want you to look at the red, which is the demand for the occupation, and the green is the number of graduates, and that largest one is, again, nursing. So as you can see, there is a far more demand for the occupation than our colleges can actually provide for a couple of reasons. And Kathy Martin was going to talk a little bit about this, so I'll fill in a few of the gaps from her presentation. All of those allied health programs are impacted. They're impacted in that we have more students waiting to get in our doors than we can accommodate. They're impacted from the fact that our clinical sites are overwhelmed and we can't add more students to our overwhelmed hospitals and clinics. We have a shortage of qualified faculty, and of course we are under-resourced, but you all know that anyway. Going back to Angela, still a little bit of my thunder here, but if you think back to 2005, and one of the reasons that nursing looks a little better than the allied health, although that will be coming up again soon because of the initiative, but back in 2005, Governor Schwarzenegger announced the the Nurse Workforce Initiative, which was part of the Workforce Investment Act funding, that was going to really expand the nursing programs. And so this was one of the responses that we did in partnership with the community colleges. And this slide just shows some outcomes. So from 2005 to 2009, we have increased our enrollments in community college, ADN, which stands for Associate Degree Nursing, by 48%. In 2009, our 74 programs enrolled over 13,000 full-time students. Dramatic increase, again, up 48%. And the bottom line talks about the investment that was made by the state of California, by $165 million. So this is a prime example of what we can do to respond to a workforce shortage. Now, Angela mentioned there's another allied health initiative. There's 2 rounds funded in that, and we'll see if we'll get some similar data. So we know that we can respond to the shortages if we have the appropriate funding to do so. And my organization, the Regional Health Occupations Resource Center, have been a prime factor in making those expansion programs possible. And I want to delve a little bit into some of the partnership aspects, and this is what Kathy was going to talk about, and that is the California Hospital Association has a healthcare workforce coalition that was established to bring attention to the allied health professional shortages. And this coalition is made up of expertise and knowledge regarding health workforce development throughout the state. They are focusing on 3 primary areas: medical imaging, or diagnostic imaging, clinical laboratory scientists, and pharmacists. And I think in your handout you have the CHA July 2009 issue brief, the hidden healthcare workforce. And we have actually partnered on those 2 areas. I'll just, as a quick aside, the diagnostic imaging and the laboratory science services aspect in the Sacramento area, and there'll be 2 new programs starting based on funding in this region that we are going to plan on using with distance education. Whenever a program starts in an urban area, my goal is to always encourage distance education to reach the more rural areas. So I know the Hospital Association is working very hard with that workforce coalition to bring attention to the issues and to really work with their educational partners. One of their premises that to fully fund the workforce, we have to fund the education and really look at what are we going to fund in the state versus, continually to looking at cuts to education in the workforce. This is just, again, the look at where the works are throughout the state of California. And I wanted to focus on one of our programs called the Welcome Back Centers, which is an excellent way to increase diversity in the workforce. There are 2 Welcome Back Centers remaining, one in San Francisco and one in the San Diego region. And what these centers do is take foreign-trained healthcare workers that have come to the United States and help them get back into healthcare. And you can look at this numbers, and we can show the success of how we have actually helped people get full employment, maybe close to their original profession, but again, back into healthcare. So an excellent way to increase diversity into the workforce for California. Again, the RORCs are part of the Economic and Workforce Development Program, and this just shows a little bit about that program. Again, I just wanted to emphasize the severe shortages in the allied health workforce. The rural communities have an especially hard time getting the workers into their region. So as we look at maintaining funding for community colleges and CSUs and UCs, we can hopefully maintain our allied health workforce. Thank you.
Thank you. Thank you so much. I had to write a note to myself because I have a little nursing education bill out there I wrote down. Good slides for a nursing bill. Call this woman. Thank you very much.
Thank you.
Okay, next, Dr. Barry Russell.
Right.
Thank you.
Thank you, Madam Chair and members of the caucus. I am currently the Vice Chancellor of Academic Affairs for the community college system, but I'm here to speak to you today about my previous job. I was the Vice President of Instruction at College of the Siskiyous in Weed, and so this is a kind of a local project that speaks to all these workforce numbers that were coming down, and the local community jumped in and decided to do something about the lack of workforce preparation in the area. At the time that I arrived in Weed, at that point we only had a VN program LVN program that trained about 22 to 25 nurses every 18 months. And that was not enough. And so the local workforce providers, Mercy Medical Center, Fairchild, came together with the college and embarked on several projects. And this is our slide to show the size and the distance proportions for Siskiyou County. And then also to show you this is basically the area that Linda was just talking about, with Siskiyou County up on the top end of that. The first thing that happened is that the community passed a bond measure to be able to build the Rural Health Science Institute. It was a vision of the previous president to have a forward-thinking location that would breed workforce development, as well as some initiatives that could serve as models for the state and for the nation as far as providing rural workforce training. So in this building, the building opened up this past October. And in this building, we currently have the existing programs of nursing, paramedic training, and EMT. We are looking at developing these other programs. One thing that became apparent to us, and much with the help of Linda and her workforce information, is that in these programs, because of our sparse population, we could not host these all by ourselves up there, that we need to partner with other rural colleges, even colleges in the urban areas, and we do that with video conferencing. So right now, we are working closely with UC Davis Medical Center, the new UC Davis nursing program, to develop some of these programs out so that we can provide the education for our local citizens to become trained in these areas by using the video conferencing system. Another event that happened is we received a grant from the Walmart Foundation and the American Association of Community Colleges. And this was an economic development focus, and our focus was on providing training for rural healthcare workers, for the workers that are already in the county, because one of the things we calculated was the cost that were being spent to send the workforce outside of the county to go to training was actually draining resources from the county. And so we wanted to keep those within the county as much as we could. So we're using the rural training center as a focus. It has a very high-tech video conferencing theater in it, and we're using that as a focus to bring that together. One of the first things we did, though, was to do a research study, and that's what the rest of the slides are about, is what we found in this research study. And we looked at from physicians and specialists all the way down to office workers. We surveyed the community and the healthcare workers in the area. We covered and canvassed the whole county, trying to find out information about what did the community need from the community college, what could we provide in the Rural Health Science Institute to provide them better information so they wouldn't have to travel out of the county. Maybe they could find the information within the county. And then for healthcare workers, what sorts of community education could we offer? And so basically there were these three questions. I think I just covered those. And the conclusions one is that the campus, the college, needed to be a local trusted source, develop or distribute community education classes, expand community service learning opportunities. One of the things we found with our nursing students is that they needed a chance to get out into the community, into the rural community, not necessarily just in the hospital. So we wanted to give them service learning activities out in the community. We wanted to develop a web portal that's hosted at the Rural Health Science Institute, but brings together all of the providers in the county so that there's one place that everybody can pool their resources, because just having a web portal is one thing, but keeping it up and going, as somebody said earlier, having the local high school student make sure it's all programmed well is a challenge. So if we could provide that in one high-tech location and have everyone come together to do that, we felt like it was a better option. Support regional local efforts to expand broadband. Sorry, that's come up several times today, is the expanding of broadband. And, when you get back in the hills of Happy Camp and Orleans and other places back there, satellite barely gets through the tall trees. Partnerships are the big thing. The thing that we have actually learned more through this grant process is that the partnerships that are created from the community college through all the workforce areas and as well as the statewide partnerships. I'm glad to say that a lot of people sitting out in this audience here participated in our advisory committee to help us with this research. And it was the statewide resources that were pooled together that made this happen. And also the external partners, the federal, state, regional workers and employers that we have attracted through the research to Siskiyou County has been huge. And then, of course, we just heard about the health information technology training. And then the synergy between health education and the professional education programs is very important. We have as small as doing internships and walkthroughs with the high school students who go to the hospital and shadow the nurses, shadow the doctors, shadow everybody in the hospital to determine what kinds of jobs they might be able to get. And then they translate that into programs that are hosted at the community college level. And then from there, they're able to go to a university system if need be to get the 4-year degree or the post-baccalaureate degree if needed. And then obviously leverage the natural beauty. One of the reasons that people live in Siskiyou County is it's a gorgeous place to be. And so we wanted to capitalize on that. And so the wilderness training that's very specific to rural areas was important for us to develop. So there's a special piece of the curriculum that's being developed for that, as well as the holistic healing seminars and other kinds of Eastern medicine that might be used. Those are being integrated as well into the curriculum. And then just to give you a view, we went from those 23 LVN students, so now we have actually 2 cohorts of LVN students. We added a second cohort thanks to some workforce investment money that came to the college. And then we also developed a step-up program for LVN students to move to RN, and we are right now developing a full RN program. So there'll be another 20 to 25 students added to this picture in another year. And that's moving closer to the solving the problem that Linda presented with the number of healthcare workers needed.
Thank you so much.
I have a question.
Yes.
This is more of a statewide question than, because I think you might have already answered it with regards to this particular project. This may be dated question, because a couple years ago we heard that some of the community college districts under pressure to reduce costs were targeting their most expensive programs, and nursing was one of them, even though the demand is one of the areas where there continues to be a real demand for the workforce. Do you know in your state level capacity whether that that trend that was starting to develop a couple years ago has indeed occurred, or have things moved away from that?
Actually, I could respond to that. Yes, the answer to that question is yes. There are some colleges that are moving away from their expansion due to funding issues. There is another round of funding for some of the nursing programs, but it's not reaching all the colleges. And because of the cutbacks in the community college funding, they have had to scale back some of their nursing programs. And there are more plans to do that.
Thank you.
One quick question also, may I? I have always had a long interest, as I'm sure many of the folks here around this panel have as well, in in-home supportive services, in the shift in the demographics requiring care for people at home. In your work at Siskiyou, and certainly from a statewide perspective, have you factored that in as far as training needs going forward? Because we will certainly be having more and more people in need of in-home supportive services, whether state supported or private. Do you have that in the equation as well?
Yes, if you looked at the
you had home
data
health aides.
That's
home
more,
health aides. That's more acute.
That's
I look
right.
at that more acute.
In-home supportive services is a different level of caregiver. That's not a. It's actually not a licensed level of staff. It's more on the social services side. So we do some training for that, but most of our training in allied health programs is more on the certified nurse assistant and home health aide, which is sort of done as a packet. But yes, you are correct. There has been an increased need for that one as well. But we don't actually have that one broken down into our demographic data as we do the home health aides, which is on the rise as well. And that also always follows reimbursements. So that kind of goes up and down based on that. So you're correct.
Well, thank you so much. We are now going to move to Dr. I hope I don't mess this up. Jutila?
George Jutila.
Okay. Thank you for correcting me on that.
Madam Chair and members of the Rural Health Caucus, it's my privilege to come here and speak to you. However, I seriously doubt whether you want to hear what I have to say. First off, I want to just say that health information technology is beautiful and it's wonderful, but it only has half the data that you need to make rational decisions. And I'll leave it at that. You can ask questions later. I've been in practice, in family practice now for 45 and a half years, soon to be 46. And in Humboldt County, which has 131,000 people and has an agricultural business of about $3 to $5 billion in marijuana. This has a profound effect on our health and our education. The transition that I've seen in the medical practice has increasingly disturbed me is a doctor-patient relationship. In every step of the way, that has been a roadblock to taking care of patients. And I want to impress on you how important that is. And it's because of the legislative, regulatory, and third-party interventions. The intrusions have gotten progressively more invasive, and the reimbursements have dropped to big box associates for physicians. Since 1991, my office has been a federally designated rural health clinic, which is Public Law 95-210. We get a global fee for seeing a patient. It doesn't matter whether I see him for a hair in the eye or for a complex medical problem. I get paid one fee, and that goes in and is paid one fee. This was a federal attempt to improve the access to medical care for Medicaid and Medicare patients. And at this time, my Medicare and Medicaid population in my clinic is 70%. That's poverty. I find that even recent retirees are falling below the safety net of the infrastructure costs necessary for survival, let alone comfort. I want to give you an example of what happens in my clinic. I buy flu vaccines. These are purchased in September. We give them October, November, and December. I don't get paid for those until the cost report goes in 14 months later. This has caused me a tremendous amount of hardship. The changes in the insurance intermediaries by the feds have not helped either. We've had several changes in the last few years, and every time we get a change, I leave money on the table because I can't collect. I'm going to talk specifically about primary and specialty physician turnover in Humboldt and Del Norte County. And in the packet, I think there are some information from Humboldt, Del Norte County about physician transfers from one place to another and for leaving. And these tables show the comings and goings of physicians in Humboldt, Del Norte County, and the reasons for changes are multiple. Penny Figas, who's our medical exec at the Humboldt Del Norte Medical Society, reports that when physicians leave the area, they often say things like, wives aren't happy, shopping, social, etc. can't afford to buy a home, reimbursement issues, spouse can't find a job. The clinic supervisor of a local medium-sized internal medicine group gave the following reasons for physicians leaving. Left because wife was unhappy. A husband and wife physician team, one in infectious disease and the other in internal medicine. They left after 1 year for reimbursement reasons and because there were no other infectious disease physicians in the area, and he was 24/7. And that's what's happening to primary care, too. He left to work for Kaiser, 8 to 5. Nice transition. But it doesn't take care of the people who need the care at the time when they need to have the care. And the major cause of that was reimbursement. Clinic supervisor of internal medicine also told me that Blue Cross has increased their premiums annually a number of times in the past, and there's never been an increase in the reimbursement to physicians, and physicians always ask the question why. And I think you as legislators ought to too. There's a lack of specialists because there's an increase in the amount of regulatory hoops for specialists. Young doctors cannot live here because they have student loans accrued in medical school and residency between $150,000 and $250,000 that have to be repaid. I can't pay them. I've had a physician in my office that I had to pay him more than I've ever made any time in the 45 years. And he left to go to a federally qualified rural health clinic. Okay? I have also been involved in trying to negotiate a reason to go into a federally qualified rural health clinic for other reasons, and I'll get to that in a minute. One of our physicians, Dr. Bella, an orthopedist, left and went to Fort Bragg to a federally qualified rural health clinic because he couldn't manage financially at our hospital in Redwood Memorial Hospital. Dr. Jones now is the only orthopedist. We used to have 3 at one time. And Dr. Jones now is on 24/7, and he's made it plain. He's gone into the St. Joseph 1206L clinic. Do you know what a 1206L foundation is? Sutter is a 1206L. Okay, and foundation at Redwood Memorial Hospital. And in a month that they put out bids for an orthopedist, they haven't gotten one thing because they advertised what they were paying Dr. Jones. There is no way an orthopedist can be in our critical access hospital 24/7, period. 3 years ago, we had 3 neurosurgeons in Humboldt County, and 2 have left. Again, a neurosurgeon has been forced to join the 1206 Foundation model. Whether another neurosurgeon can be secured is highly questionable. 2 years ago, Dr. Huppenbauer, internal medicine at Redwood Memorial, retired, all because of reimbursement costs. He moved to Bali, and he's able to get medical insurance for himself for $250 a month, good for any place in the world except the United States. I hope that rings a bell. Over the past several years, Humboldt County has lost 2 ENT specialists, leaving only 1. A fortunate graduate from the University of San Diego Medical School will be arriving in July of 2010. I hope he gets enough reimbursement to survive. Psychiatry has almost become non-existent in Humboldt County. If I have a patient that I have to have psychiatric care, there are no more private psychiatrists in Humboldt County. They've either died or they've moved to the prison at Pelican Bay. I have to depend on the mental health, and I'm sure you recognize that the mental health is already overstressed. The community hospitals in Humboldt and Del Norte counties are recruiting the following physician categories as of December 2009. Mad River Community Hospital, internal medicine, OB, wound care, hyperbaric medicine, emergency medicine. Redwood Memorial Hospital, internal medicine, family medicine, emergency medicine. St. Joseph Hospital, cardiology, plastic surgery, neurosurgery, OBGYN, emergency medicine, urgent care, pulmonology, oncology, and general surgery. Sutter Coast Hospital, which is another 1206L foundation, needs OBGYN, pediatric, internal medicine, and even into Brookings, Oregon, and general surgery. I think you can see that there's a major problem. It takes 20 years to get a cadre of physicians out there. And if you're not going to pay them enough to pay off their debt, I don't understand how they're ever going to be able to survive. And why is there any incentive to go into medicine? There is no hope for private medical practice survival in Humboldt, Del Norte counties unless a doctor joins a 12OL foundation model, a federally qualified rural health clinic, or join government-paid positions such as a prison. Where does that leave patients? Without practicing physicians, patients in rural communities have no choice but to engage the most expensive medical care. I've had a Medi-Cal patient go to the emergency room because she didn't have $4 to buy some cough syrup. And the most expensive medical care, which is delivered after tax dollars for those who have to pay their own way, at emergency rooms, hospitals, and now concierge medical practices. You're going to see that boom in the next year. The real problems with the practice of medicine are the middlemen behind the scenes adding to the cost of health care and interfering with a physician-patient relationship. There isn't a day that goes by that I don't have to sit there and argue with an insurance company about giving a medication to a patient, even though they've been on it for years. Physicians are at the mercy of unilateral contracts with health plans, insurers, third-party administrators, silent PPOs, all of who enjoy antitrust exemption under ERISA. Physicians have no antitrust exemption. We can't even talk among one of us about how much we can charge or how much we do charge. Okay? The ERISA allows people, the health insurance industry, the third-party administrators, and all of their other things to take personalized health information, publish it, and put it in a public restroom, and the patient has no recourse, and you have no recourse as a physician. Meanwhile, physicians cannot even talk to others about financial matters, and we're bound by HIPAA with big fines. Under ERISA, entities exempted from HIPAA requirements are free to engage in criminal activity against patients, physicians, and other HIPAA-compliant entities. Take that statement seriously. In short, legislation and regulations have left physicians without adequate reimbursement to provide for their families and forced to be charitable to those who are drowning in poverty. And by poverty, I mean economic, social, educational, environment, self-discipline, and other evidence of poverty. And I can give you the reasons for that if you want. The current medical care delivery system infrastructure is so broken, I see no reason to return to a functional, inexpensive medical care delivery system in the United States. The system has been stolen by the pirates of profit. Currently, I see the legislature, Congress, and regulators trying to put on a beautiful paint job on a completely rusted vehicle called medical care delivery and selling it to the public as a functional system. Pretty hard things for someone to say, but that's the reality from the rubber, where the rubber hits the road.
And we do appreciate it. You certainly can.
I want to thank all the members of this panel. Dr. Jatila, some of your comments resonate very strongly. One of my concerns about the rush to the electronic records, and I'm sold on the efficacy if it doesn't take away from the doctor-patient relationship. And one of the people who testified earlier said there'd be a 30% reduction in the time available for patient care to maintain the electronic records. So who's factoring in to patient visits and access to this sacred relationship? I referred to my wife earlier, a family practice physician, in a public clinic, family practice doctor. In August, they saw 2,800 patients, 4 doctors, 2 mid-levels, and during the course of trying to service those 2,800 patients, they were interrupted by drug reps trying to push certain drugs on the clinic and on the prescribing practices. They were interrupted by other vendors, and they were trying to see these patients in the frame of 10-minute visits, and a long visit is a 15-minute visit. I know when I see constituents, we schedule a 15-minute visit, and it's always inadequate, and they don't have to take their clothes off before that visit.
Well, thank God.
Thank goodness. But by way of empathizing with the plight not only you face, but other public clinics, primary care providers, and how it's exacerbated in rural and underserved districts. One thing we haven't heard much today, you made a comment, Doctor, about some of the shortcomings of reform proposals. But I know everyone's focused on their area of expertise, but we need to start looking at universal remedies because the system is broken. I'm a co-author of a Senate Bill 810. It's a state effort to achieve single-payer health care that would remove some of the middlemen that you talked about. A lot of my wife's practice is not with patients. It's fighting with insurance companies to try to secure authorization for prescription, and as you said, often for medicine that's been prescribed before. So I'm not really asking a question here. I'm thanking you for your presence. I do think we have to keep in the forefront. How do we evolve in terms of this workforce issues and have front and center preserving the doctor-patient and the provider-patient relationship? I'd strongly recommend a book called The Lost Art of Healing and how technology has taken over the delivery of medical care in this country. We need to, as we move forward, get better in terms of patient care and outcomes, starting with preventive care and moving through treatment. So, again, too often we get caught in these silos of these different areas that we're trying to address. And so I just encourage all the panelists today and what we can do as legislators to see what are the broad reforms that are going to create the environment to preserve this relationship.
I feel a whole nother panel coming on, a whole nother hearing.
Another hearing.
Thank you.
Can I make one comment? I made a statement to begin with that this health information technology will fail. Did any of you think about why I said that?
The computer chips are going to melt down.
No. I'll tell you why. I'll tell you why. The House of Medicine abdicated its responsibility to keep patient information private. We should be having medical data encrypted so that anybody can fish in there on any disease, any problem, any patient without knowing who that patient is, okay? We also need, at the same time, the ability to have and track the cost of every item that is handed in terms of medical care. When a patient comes in to me, I would like to say, oh, I think you've got a gallbladder. It's going to cost you $5,000 at this hospital, $3,000 at that hospital. Yeah. That should be able to be done through a data warehouse, okay? So you have to have financial data warehouse along with the health information, and that's the only way we're going to get out of this box.
Well, I do appreciate, Doctor, believe it or not, the information, because I think we work best when we have full information in front of us, both sides of an issue, so that we can look at all of the aspects of that. I'm going to beg your indulgence. We have one more panel, and I know that they can do this quickly, but I don't want to leave without giving them an opportunity. Everybody's been patient and been here for a while, so if the next 3 panelists are here and they'd like to come up, I will stay. If the rest of you can't, that's okay. But we're here, and you've waited, and we're happy to have your testimony now. So, Peggy, we'll start with you.
I am Peggy. Thank you. I want to start by thanking you, Assembly Member Conway, and all the members of the Rural Caucus for your leadership and your continued support of activities in rural areas of California. Again, I'm Peggy Wheeler, and I serve as the Vice President of the Rural Health Care Center at the California Hospital Association. That's who I am now. I do want to go back just 6 years and let you know that as the result of a pilot program through the California Endowment, I was and continue to have the title of being the only health policy analyst that served just the members of the Legislative Rural Caucus. Unfortunately, the California Endowment wasn't able to continue that funding, but I would say, and you probably would support, that that kind of staffing to the Rural Caucus would be very helpful in the future. That way you'd have that direct line into health policy data. Rural California will continue to face the many challenges that you heard about today. I'm going to take just a few minutes and tell you what rural California has going for it. You've heard it before. Innovation is key in rural California, and in our rural areas, it's really been born out of necessity and financed primarily with good intentions. That will continue. Collaboration and cooperation. Many of the rural healthcare providers have for years collaborated and cooperated with each other because that was the only way things were going to get done. And finally, I would say that our rural areas have champions and heroes like you wouldn't believe. You would think that probably today you've heard from them as they've come up to the podium. But even they would say that the real champions and heroes are the ones you never see, the ones they work with every day, the nurses, the CRNAs, the lab techs, all the way to the bank president that continues to extend that loan beyond the terms so that they can keep their doors open. Those are the real champions out in those communities. What we would ask of you is what you're already doing, continuing to provide the unwavering support and protection, primarily protection in this current budget environment, of those policies and legislative proposals that will continue to support the fragile rural healthcare infrastructure. And then finally, continue in earnest to educate your urban brothers and sisters in the legislature about the problems facing rural, and that the one-size-fits-all philosophy just does not work for rural California. Thank you very much for your time today.
Thank you so much, Peggy. You're a resource. We want to make sure that some of us are new, so we didn't have an opportunity to work with you before. So.
Madam Chair, I apologize. I have to leave, but I just want to thank everyone and thank you for your leadership.
Thank you, Assemblywoman. And speaking of Assemblywoman,
Former.
You're never former. You used to be my Assemblywoman at one time.
That's true.
Welcome back to the big house.
Yeah.
The big house isn't always a good thing, right?
Next with us is Sarah Reyes.
Thank you,
Welcome.
Madam Chair and members. I am glad to be here before you speaking on behalf of the California Endowment. I'm the Senior Program Officer for the Central Valley for the California Endowment. As you've heard today, the Endowment is very committed to supporting efforts for rural health care and rural health access issues throughout California. Currently, as I passed around a packet of information to all of you, we are beginning the process, or actually in the middle of the process, of our Building Healthy Communities plan. It is a community-based initiative that is happening in 14 communities throughout the state of California. This plan is a 10-year commitment initiative by the endowment to go deep into communities, and actually it's a different way of looking and foundations working in communities, because what we've done is we've gone into these communities and asked them, what do you need for your community to be a healthy community? And so that planning process is going on currently. 6 of those sites, of those 14, are rural sites: Del Norte, East Salinas, South Merced, Central West Fresno, South Kern, and Coachella.
I can tell you've been to Crescent City because you pronounce it Del Norte.
I did okay?
You did great.
I will tell you that those rural communities have come together to look and to lift up some of the issues that you've heard today and how they can work on these issues in their own communities. The program officers assigned to those communities from the California Endowment have also come together to also work together on rural issues and rural health issues throughout the state of California. It's our hope, for example, that we can do some good work in these communities as and I'm not going to try to say his last name, I'm just going to call him Dr. George, that his community in Dal Norte could help in recruiting and establishing efforts to recruit good practitioners and medical practitioners in his community, as well as hopefully helping with the bureaucracy that's going on there. In South Merced, for example, the healthcare issue in our South Merced communities is violence and violence prevention among young people who also see on a daily basis the violence going around and the difficulty that rural sheriffs have to do in order to get to those locations. In Coachella, it's the lack of basic infrastructure. When you talk about broadband and internet, sometimes you can't even get it in these small communities. You don't have to go to a mountain community in order to have those issues. And so these sites are working together to try and build those healthy communities. These are going to be plans that the endowment is committed to working and partnering with these communities for 10 years to move forward to improve the healthy community that they live in and hopefully improve all of rural health in the state of California. We would be happy to share those plans so that you can see what your communities are saying and what people in these planning teams, because it's residents, it's youth, it's practitioners, it's systems officials all coming together, leaving their egos, their agendas, and everything else at the door, but coming together to say, we want our community to be a healthy community, and this is what we need to make it happen. And we are just glad to be a part of that effort. So I thank you very much.
Thank you so much, Assemblywoman.
All right. Since you've already heard from me once, I will...
You got to open, and now you get to close.
Yes, and I hope to leave it on a more positive note. I would argue that healthcare in America at the moment is in the battle of all of us trying to become better blacksmiths when it was time to become an auto mechanic, and that there are significant changes happening that we need to look at those opportunities and let go of some of which the past has had. The role I believe that the caucus needs to play is to make sure that our partners in the urban areas recognize the need for a healthcare infrastructure in rural and maintain what we have and begin to look at what it is that we still need. We're now talking into the future, knowing that the resources are very limited. A suggestion that I would have, putting my hat on as a California citizen and taxpayer, would be, what do I already own as a taxpayer in the state of California in rural? And I think we often think of ourselves in only a silo kind of mentality. I'd love to GPS map every CDF office, every Bureau of Land Management office, every CHP office. I'd like to see what we as taxpayers are already supporting across our whole state. And then begin to look at how much would it cost for us to drop a 2-exam room, double-wide trailer into a CDF office out in the middle of Orleans or Forks of the Salmon or in many frontier areas. Use the technology that is coming to our disposal at this point with broadband. Make sure that the last mile issues are the parts that you focus on as the rural. There is no doubt that the energy to build the backbone and even the limbs out from the backbone is there, but it's that last mile, it's getting it actually to that place that is going to be expensive. Connect the existing infrastructure in rural today with those new sites where you don't have any rural access already. So don't try to create something new, but go to Ridgecrest and see whether, and it's been a long time since I've been in that part, but if Lee Vining needs an access point, hook it up with Ridgecrest. Hook it up with the providers that are already there. Give them the technology so that we can do talent sharing. One example that we've been using in Del Norte County, we have a relatively large Hmong population. It is very hard to deliver good, anonymous health care when the translators that you need for delivering that health care come from the community itself. So it's either your aunt, your uncle, your brother, your cousin, or somebody. The ability to be able to hook in with our technology and talk to Merced, where there is another critical mass of Hmong, and we can use somebody that you don't know to be the person that works with our providers, all of that is at our fingertips. Open Door Clinic, I just bring that up as an example. We have 1.2 million charts. Now, I'll admit I've been there for 33 years. In our whole area, counting Del Norte County and Humboldt County together, we have 160,000 people. So we ourselves have a factor of 50 times as many charts over a period of time. We're constantly, 5 times, sorry. We're constantly seeing people moving through. I bring that up because it is very expensive health care to have to start over every time somebody moves. It's bad medicine, and it's even worse economics. The fact that we are moving toward a population and data-based healthcare system is going to be good. When that patient leaves our practice to take care of grandma in Alabama, hopefully they will have 30 access points along the way that they can drop in and take care of their diabetes or their asthma or whatever the other condition is, and have that information available so that provider at that site has the ability to care for that patient without having to start over. Those are the kinds of things that the electronic medical record will bring us. Those are good issues. The last issue that I want to bring to your attention is that the way we pay for health care at the moment is so broken that getting to that next level is going to be extremely difficult. At the present time, every single service that's provided in Dr. Judula's practice has to run past Dr. Judula or his partner to be able to get paid. Even if that diabetic would be better off being guided by Dr. Judula, but maybe meeting with a dietitian or meeting with someone else who does exercise classes. Nothing gets reimbursed. We can't use other talented individuals in our practices to deliver health care services because everything at the present time has to move through that primary care provider. That is an impediment that can only be solved at your level. We have excellent workforce in this state that could deal with mental health issues, with diet issues and the like, who are presently not billable providers. We're not necessarily asking them to be able to be billed the same way a doctor, but there should not be a reason that for you to have to see your doctor to be able to get access to a dietitian. So I actually see a relatively bright future ahead for health care. The short distance of getting us through this and not having collapse in rural areas, what we presently have, is the biggest fear, and that is the issue. The very last thing I would say is you also have an obligation to create batons that you pass because of our limited opportunity to keep our legislators right about the time that you really become good at what you're doing. You're out of there, you know. You can play a Wesley, but that gets you, what, another 6 years? I mean, as a taxpayer, I feel really at a loss. Certainly in medicine, we would not go ahead and say after 6 years, you're out of there. We don't want you to be a doctor anymore. Go do something else now. That is a big problem. It is reality, but it puts an extra burden on you to make sure that at least your staffs who will move on and stay here have the knowledge base that's necessary to solve some of these problems that are bigger than the term limits that presently exist. Thank you.
Thank you very much. And I really appreciate all of you that came and gave testimony. All of the thoughts and ideas are great ones. I do especially want to thank the California State Rural Health Association for your great help and work in making this happen. I had promised earlier that if someone absolutely needed to give us some public comment, and you've come a long way, if there's anyone out there that has a burning desire to do that, I will take that testimony myself right now. I think if we hit that first microphone and just use that. Once again, thank you to every panelist. I'm inspired to maybe do this again soon because it was great, and I learned a lot. I really try every day to learn something new, so I'm hopeful that we can share this. I really appreciate the Assembly members that were here, and maybe we can share this with our colleagues to make sure that message gets out. So I'm going to take some public comment right now, sir. Just hit the white button. Is there a white button?
Is that better? My name is, thank you very much for listening to us, members of the Senate and the Congress, as we listen to rural health medicine. I'm from Tulare. I live in Dinuba, so you're my representative.
Oh, boy.
Okay.
You caught me working. I don't know if that's good or bad.
I want to say that rural health medicine has many challenges that we all face, and we have one that's so bad right now that it's shutting down the infrastructure in rural health medicine. And I feel like I'm up here saying to you that I am a ragtag fugitive fleet fleeing from the Cylon tyranny. And the Cylon tyranny is Blue Cross and Anthem. They decided in 1997 that they were going to eliminate all rural health clinics in 6 months. Everybody signed a contract except me. I said, no, I'm not going to sign a contract. They came to me and asked me to have one done. I said, okay, give me one and I'll sign one now. They said, I'm sorry, we're Blue Cross. I want you to sign a contract effective as November so you can be out of business like the rest of them in 6 months. I said, no, I won't do that, but I'll be happy to sign one today. The president of Blue Cross Managed Healthcare at that time was John Monahan. The minute I said, I'll sign one today, he blew his stack. He said, no provider's ever going to do this to me. Nobody's ever done it to me before, and you're not going to be the first one to do it. And I said, John, let's get reasonable. And he was yelling at the top of his voice over this. This was not just a normal conversation. I said, okay, I can't live with November. You can't live with March. Give me one I can sign. He says, how about January? I said, okay, in January I'll sign a contract with you, but I want the same contract that I get 6 months from now that I have today. And he said, we'll see. So I showed him what our clinic was doing. We're a preventive medicine clinic. We're not the traditional rural health clinic. Our average visit per patient is 1.3 a year. We do a lot of preventive medicine. We do a lot of education. And 5 months later, they came back and said, well, John, we want to sign a contract with you from now on in Dinuba Medical Clinic, but we have to make all the other rural health clinics whole at the same time. I now sit here again, since this has been 97. We're now at 2010. Anthem Blue Cross and WellPoint have been now assaulted again, the rural health community, under the managed care line. And what they have done in their managed care area, from 1997 till 2009, they paid us regularly, on time, without any problems. Last year, they said that they'd lost money. So what they did is they turfed off all the money that the state of California, that us taxpayers gave to them to run managed care, and they picked on 3 or 4 little IPAs. And what they did is they gave the poor little IPAs $32 per patient per month to try to provide health care to all the rural health clinics. Well, the IPAs probably weren't smart enough to realize that doesn't work. But I told them at the time, it's not going to work. That's not enough money. So Blue Cross kept all the rest of the money for last year. And they gave the IPAs $32, and the IPAs sunk, and now I'm out $300,000 that I can't collect, and Blue Cross says I'm not responsible for doing that. They were the primary contractor. The IPAs were a subcontractor. I shouldn't be held by not having the main contractor that set this thing up pay for those services, and they've done them to all the rural health clinics in Fresno and Tulare County because they were losing money. And I encourage you, as you expand managed care and go forward, don't sacrifice the rest of us by allowing a proprietary organization who, when they first got into it, paid John Monahan a $5 million bonus because he did such well because he took all the money out of rural health, and then changed to a for-profit, a nonprofit entity, and gave away $100 million of the money that they were supposed to provide to us so they could maintain their profit ability, and so they could be nonprofit. Stop this, please. We need help.
Thank you. It sounds like you and I might need to have some conversation offline. My chief of staff is right there. Make sure he gets your information. Okay, anybody else would like to comment? If not, yes? Okay.
I just want to say thank you for staying overtime, as we say. My name is Dr. Jan Cooper, and I'm an optometrist. My background is in community health centers, and I'm also a member of the California State Rural Health Association and serve on their advocacy committee. I'm the incoming chair for the American Optometric Association Community Health Center Committee, and also trustee for the California Optometric Association. However, I do want to get on to why I really am sitting here for you. In 1996, the Institute of Medicine provided a report, and they named optometry as one of several professions that is able to deliver the primary health care as a primary health care provider and primary health care services. And an understanding and knowing the workforce issue and the access to care issues in rural health and in the urban areas, also community health clinics, what we can offer is some part of the workforce that can step up to the plate to work in coordination of care with the primary care providers. Optometrists are primary eye care providers. There's some definition issues between specialty and primary care that right now AOA is working with HRSA to try to help change the definition. But we're able to help coordinate the care for over 50 systemic diseases, for example, diabetes, well known, hypertension, thyroid disease, and a multiple of other diseases that we can diagnose, and also in some situations, if there's ocular manifestation, we can treat it, but we can coordinate the care with the primary care doctor. So I'm just bringing this to light because there's so much more that we need to address with the eye care from, as we say, from cradle to grave, to helping the children, not overlooking the children, because the number one problem for children is visual disability when it comes to disability issues. And then, of course, we've got the adult population with all the chronic disease. We also play an important role in preventative care. For example, tobacco cessation. We can use the opportunity to educate the patient about the risk factors related to smoking cigarettes. Cataracts, macular degeneration are highly caused by smoking cigarettes in addition to exposure to ultraviolet light. So I'm just bringing this to the attention to everyone because my profession, and I've spoken at great lengths to my local society, the California Optometric Association in the state of California, and we're willing to step up to help. So from that perspective, I want to leave on a positive note that we're here to help also to help provide another component of the care, improving the outcomes for these people. Thank you.
Thank you very much. Appreciate you waiting all that time to address us. And so with that, once again, I really want to thank each and every one of you that either came today to listen or to serve on a panel.
or to provide us information. Again, thanks to the Rural Health Association. Both of you right there. I appreciate it very much. You did a lot of the work. To everybody, we went a little overtime, but hopefully it was good, healthy dialogue, and I appreciate it very much. Thank you all.